Ladies and gentlemen, Your Excellencies, welcome to the Swiss Healthcare Innovation Day. I'm Johannes Stralla, a journalist with Estonian Public Broadcasting, and I'm honored to guide you through today's conversations. Now, we have a room full of people who shape the healthcare sector from every angle. We have policy leaders, hospital managers, digital health experts, and innovators. And that is exactly what we need, because the challenges that we're facing today won't be solved by one stakeholder alone. Nevertheless, it's hard to ignore the contrast and irony between our surroundings and the topic that we're discussing today. This Baroque palace with all its beauty, history, and art reminds us what wealth once looked like. And in this luxury setting, we'll be discussing, well, in a way, how to do more with less, but definitely how to use our resources better. Ladies and gentlemen, you all know the numbers. People are living longer and need more care. The workforce, at the same time, is shrinking. Healthcare costs are growing faster than tax revenues. In Estonia, our health insurance fund is already in deficit. By 2040, that gap could reach over €1 billion if nothing changes. And Estonia, of course, is not alone with this challenge. But dear friends, we're not here to repeat the problems. We're here to hopefully ask better questions. What if innovation and healthcare could not only improve outcomes, but also drive economic growth and resilience? Today we'll tackle that idea from several angles. How can we actually use the data that we collect to improve outcomes and decision-making? And in Estonia, we have a lot of data. Our systems are very digital. Can we actually use this data to improve our health policy? Now, what does real public-private collaboration look like beyond a few successful pilot projects that we've also had in Estonia? And how do we shift from reactive systems to smarter and more sustainable health models? Because in the end, healthcare doesn't only have to be a cost. It's not just a cost. It's one of the most important investments a society can make in people, in productivity, and in long-term stability. Now, a quick note before we begin. If you'd like to join in the conversation, please take out your smartphone and go to a web address, slido.com. Now, when you enter the password, SwissInno, or you can also scan the QR code, which you see on the display, you can ask questions throughout the day. Those questions will magically appear on a screen in front of the stage, and then I can take them to the panelists. Ladies and gentlemen, to officially open the day, I'm very pleased to welcome someone who has helped build bridges between Estonia and Switzerland, and whose support has made this event possible. Please welcome Mr. Martin Michelet, the Swiss ambassador to Estonia.
Honorable Minister, dear Dr. Colombier, distinguished guests and friends, I'm truly honored, and it's a great pleasure for me to welcome you to the third Swiss Healthcare Innovation Day, this time in beautiful Tallinn, Estonia, in this magnificent venue. Roche and Novartis, two leading innovative Swiss-based healthcare and pharmaceutical companies, are our partner for this event, and I would like to extend my sincere thanks for their partnership and to all the colleagues involved in the practical organization of today's event and for their support. As I mentioned, this is already the third edition of the Swiss Healthcare Innovation Day. When we hosted the inaugural event in Riga, I had just only started my tenure as Swiss ambassador to Estonia to Latvia and to Lithuania. And as we gather today, 1 year after the event in Vilnius, it's already the third edition and in a way my farewell event, a personal milestone for me, and I'm really glad and proud of this journey made with all of you and with the colleagues at the embassy and at Roche and Novartis. A lot can and has happened over the course of 3 years. We've explored how breakthrough innovation can be adopted early and brought to patients. We have delved into digital health, and we have examined development in biotechnology. This year, our focus turns to health and economics. How can healthcare policies support economic growth? How can data and AI ecosystem not only enhance health outcomes, but also strengthen economic ambition? The insights we gain today will be relevant in Estonia and in Switzerland alike, and I am certain that they will also be of interest to our Latvian and Lithuanian friends. Warm greeting to everyone joining us online. While the topics have changed, the main focus on innovation remains. Switzerland is often topping international competitiveness and innovation rankings, and I do believe that makes my country a strong and attractive partner in Europe. As for this event, it has almost become an unofficially official slogan: innovation saves not only lives, but also money. And this is relevant for every country and for every government, especially nowadays. This year, we are pleased to welcome Dr. Carsten Colombier from the Swiss Federal Finance Administration, who will share insight on how improved healthcare outcomes contribute to economic growth. Ladies and gentlemen, it's a true pleasure to see so many of you here in this beautiful Kadriorg Palace. I look forward to a day filled with enriching, actionable dialogue and collaboration. Thank you for being here, and thank you for your attention. I wish you a productive and inspiring day ahead. Thank you for your attention.
Thank you, Mr. Ambassador, and what a modest farewell event you have organized, indeed. It's a pleasure to be part of it. Now, we often hear that health and economy are in separate conversations, right? But in reality, actually, are they very deeply connected? A healthy population is obviously a productive one, and good healthcare policy is, in a way, economic policy. And yet many countries, including Estonia, still treat healthcare primarily as a cost. Financing is fragmented, innovation is often underfunded, and while long-term sustainability, if you look at the prognosis, not really looking good. So today we ask, are our current health and economic policies actually working together, or are they in separate silos? And what can we learn from countries like Switzerland? To explore this, I'm delighted to welcome someone who brings deep insight into the financial side of the healthcare systems and who can help us to see a bigger picture. Please welcome Dr. Carsten Colombier, Economic Advisor at the Federal Department of Finance in Switzerland.
Ladies and gentlemen, I feel very honored to be invited as a speaker to this very well-known event in the meantime. And I just want to talk a little bit about the macroeconomic perspective on health economics. So it's a bird's eye view that I take. I just say it in front of my speech. Now, first of all, let us look at the goals for a health system, which are formulated by the World Health Organization. It's about the improvement of the population's health condition, and in particular, it's about equal access to healthcare and also universal coverage. And that's for sure, it should be focused on the needs of the whole population. However, usually regulatory rules follow intermediate goals that are more concrete than the overall goals of the WHO, excuse me. This is the equity. This deals about equal access for the whole population to healthcare services, about the quality of healthcare service, and in particular, from an economic point of view, important is the efficiency of the health system. It's about the organization of the health system. And what is relevant for the public finances, for the public budget, but also for the social health insurances is fiscal sustainability. Thus, in the long time, healthcare services should be financeable. And last but not least, since the COVID-19 pandemic, a new criterion has come up. It's resilience of the healthcare systems, that at all times shortages should be avoided in a health system. This is also of utmost importance as well, but I do not go into detail with respect to the resilience aspect. And now, let us talk a little bit about the economic basics for the high regulation, for the heavy regulation we have in healthcare. And the most important point is that health is viewed as a key to equal opportunities in a society. If somebody does not have good health, then it is difficult to develop his own personality, his own career, and he cannot be or she cannot be successful in the labor market. This is very important. And a very important insight of health economics is the fact that we have a merit good. So the social benefits are much more important than the costs and the social costs of healthcare, of health services. And from an economist's point of view, we have a fear due to market failures in the system that we have an under-provision of healthcare services, and this is the reason why the government is so heavily, or does so heavily intervene in healthcare, in the healthcare sector. So health is a basic need, and that is key to our well-being. And what is also important for the growth, for the possibly growth-enhancing impact of healthcare, is the fact that health is viewed as an important element, as I said already, for the development of a personal career, of an individual career in the labor market, is human capital accumulation. It's an element of human capital accumulation. Now let us first start with the cost side, which maybe most of you are familiar with. It's the development of healthcare expenditure in terms of GDP. And here in this figure, I have made a comparison between selected European countries and Estonia. It is shown the ratio of healthcare expenditure in terms of GDP from 2000 to 2022. And what we can observe is the fact that in all countries, healthcare is rising in terms of national income. So it becomes ever more expensive in terms of GDP. A rising share of our national income, of our aggregated income, is devoted to healthcare in all of our societies. Now, if we have a look at the Estonian case, which might be of most interest to you, this is a solid red line shown in the slide. You can see that we start from a very low position, from a very low level in terms of GDP. It's about 5% in 2000. But we also see that we have an increasing trend there. But still, also in 2022, the level compared to developed European countries, such as Switzerland, Denmark, or Germany, for example, is very huge. We have a very huge gap. So there's still a lot of potential. Now, what are the most important drivers of this development? One of them, for sure, that you all know, I don't tell you something really new about this, is population aging. And here in this slide, we can document why population aging is an important driver of healthcare expenditure. And we show here a projection by Eurostat for some European countries, selected European countries, and also the Estonian case for the projection period from 2022 to 2070. And what we can see here is the ratio, the old age dependency ratio, the ratio between the people aged 65-year-old and older to the working age population. That is a relevant indicator for the pressure from population aging on healthcare expenditure. And the solid red line shows here that the Estonian population will be aging very fast until 2060. And this is a rather long time. Because in other countries, for example, we have, due to the baby boomer generation, we have only an increase or a higher speed of, an accelerated speed of aging until the mid of the 2030s. So that's a huge difference. So it seems to be that population aging is a more important problem, even a more important problem than in other European countries. Now, another point is, which has also the first speaker touched upon, the moderator has touched upon, is the relationship between an increasing life expectancy and the health condition of the population. So this is a very important point, and usually one differentiates between different hypotheses on this issue. There are competing hypotheses. Pure aging, if the population gets older, does it get older in a healthy condition or not? And if it gets older in a healthy condition, such as is believed by the people who support the healthy aging hypotheses, then it also mitigates the cost growth of healthcare services. Now, unfortunately, the empirical evidence is mixed on this issue. So we don't have a clear-cut picture with regard to the different hypotheses on longevity. But we know if the people get older, healthier, then it's better for healthcare expenditure. So these costs can be contained if the population gets older in a healthy condition. Now, let us skip to other factors that might impact the growth of healthcare expenditure. Here we have a multitude of economic factors. First and foremost, there's the income growth, because if a society gets richer, then the demand for healthcare services is growing. On the other hand, also the purchasing power parity of the population or of a society is growing in such a society, and as a result of this, medical innovations become more attractive. The markets grow for medical innovation in such countries. Now, medical progress itself is also a cost driver. Also, it is also highly beneficial for the health of the population. It's also a cost driver on the other hand. I will come back to this point later on. And what is also important in healthcare, it's a labor-intensive service. And as a result of this, it has a slow productivity growth, and this leads to a relative price effect. This means that inflation in healthcare is higher than overall inflation. And this phenomenon is called Beaumont's cost disease. And secondly, because of population aging, we will envisage labor market shortages, in particular for doctors and nurses as well, in many countries. So, and there are other effects as well. There are also political and institutional factors. Why is this the case? I also want to emphasize only one point. We have in healthcare, it's a very complex system, and we have a lot of groups with vested interest in this system. In particular, the providers association are small groups, and they are very homogeneous groups. And because of this reason, they have much political power. So they can influence political decisions. This is also true, for example, for the pharmaceutical industry or for the medical device industry as well. And therefore, we have also what is called in economics regulatory capture, because usually we have a kind of revolving door effect. The people who work for the regulatory of the government has before worked maybe in the industry that is regulated, and therefore we have this impact that the interests of the industry are much more higher evaluated than the interests of the population of the country. This might be the case. And there are other political and institutional factors as well, but I don't have the time to go into detail with respect of the other factors here, re-election motives of politicians as well. It is difficult to shut down, for example, hospitals. It's not very popular among the population to shut down hospitals, that's for sure. So, and also other points here. And now I come to the main theme of this event. It's about the relationship between the healthcare sector and economic growth. And as I already said, medical innovation is a very important factor also for economic growth, because it does support the health status or the health condition of the population. And as a macroeconomics, we usually discern between two kinds of innovations. On the one hand, we have process or organizational innovations. What does it mean? It means that we can produce the same level of output, with less inputs, with less resources. This is output efficiency. This is the healthcare output. And the healthcare output is about the quantity dimension. So, for example, for the number of treatments, it's the number of hospital admissions, it's the number of doctor's visits, for example. So this is about health output. So the quantity of health services, and if we have an increase in output efficiency, this would mean we have an increase in productivity growth of the healthcare sector, because the added value of the healthcare sector is increased in this case. But the second dimension of the healthcare sector is special. And this makes a difference, for example, to the production of mobile phones, to the production of televisions, to the production of cars. We have a quality dimension here, which is much more important than the output dimension. And this is about health outcomes. And health outcomes the health outcome of the population, which is usually measured by an indicator for the mortality or for the morbidity rate of the population, is influenced by many factors. And one of these many factors is the healthcare system or are the healthcare services. Others may be, for example, a healthy lifestyle, maybe, for example, the environment where we live in, maybe, for example, the work conditions under which we have to work. So there are really many, many factors. So an increase in outcome efficiency would mean that we have an improvement of health outcomes with the same resources, or we have a stable level of health outcomes with less resources. This would mean an improvement in outcome efficiency. Now let's go to medical innovations, as I told you already. So we have a process or organizational innovations, and this is about output efficiency. So process innovations lead to an increase in the best case, to an increase of output efficiency, an increase in productivity growth. This can contribute to the overall productivity growth of an economy. Secondly, and this is the predominant kind of innovations in healthcare, these are product innovations. And in the best case, these innovations are effective on the one hand and are cost efficient on the other hand. So this would mean an increase in the health outcome of the population and in outcome efficiency. And as we will see later on, that this will also increase economic growth. So what what are the health policies that could foster medical innovations? At this point, I can only provide a bird's eye perspective, very general view. I cannot delve into the microeconomic sphere here because I don't have the time. First of all, it is of utmost importance to implement an effective health technology assessment. This is decisive, because otherwise you would adopt technologies which are, in the worst case, not effective and, on the other hand, also cost inefficient at the same time. And that would not bring about an increase in outcome efficiency. Secondly, one should promote incentives for process or organizational innovations, for example, by implementing integrated care. This would help to reduce treatments that are repeated, the same treatments that are repeated by different providers, for example, general practitioners and specialists at the same time. This would help. And moreover, demand management might be also important, but I don't touch upon this point. And another fact is Bormund's growth disease. This has also a bearing on the productivity of the health sector itself, because this results from Bormund's cause disease, which I talked about earlier. And due to the fact that the healthcare sector overall is a very labor-intensive sector, we have slow productivity growth, and healthcare sector is a typical epitomizes a labor-intensive service. And according to Bormund's hypotheses, the labor-intensive service has assumed a growing share in GDP over a longer time. And so if the whole economy, if an ever-growing part of the value added comes from personal intensive services, then the productivity of the overall economy slows down. So we have, due to the structural shift of nominal GDP to labor-intensive services, we have a slowdown in productivity growth. And this can also come from the healthcare sector as well. So the healthcare sector can also contribute to a slowing down of the productivity growth of the whole economy. So health policies. We should improve the measurement of healthcare services. We have all around, we have measurement problems in healthcare because we cannot discern properly between prices and amounts. What does it mean for productivity growth? We cannot measure productivity growth really decently well. So it's not very exact. So what would also help non-wage incentives for health workers, and we should improve the labor market outcome through an increase in health outcomes. So an improvement in health outcomes is also very crucial for serving the aim that the healthcare sector can contribute positively and to an important size for productivity growth. So the improvement in healthcare outcomes supports the accumulation of human capital, and this would support productivity growth of the overall economy. Moreover, it would help to raise or to increase labor productivity growth and also the labor participation rates. All those channels would help to accelerate the overall economic growth of an economy. And empirical evidence confirms this channel. It confirms the fact that indeed a better health outcome leads to higher economic growth. And what is not clear, because we have, as I said, a multitude of factors that influence the health outcome of the population, healthcare spending itself can also help to improve health outcomes and thus economic growth. Now, this brings me to the concluding part of my presentation. First of all, we have continuous cost pressure. This means that we have to unlock efficiency potentials of our system, that we should optimize the allocation of resources between different healthcare sectors, subsectors of healthcare, such as outpatient versus inpatient care, and we should promote preventive care. Moreover, health policy can positively affect economic growth through the labor market channel, as I already pointed out, and therefore health measures can be viewed as strategic investment that can themselves support cost mitigation of the health system. And from my point of view, as many factors increase the health outcome of the populations, all policy of the government, all measures of the government should also be assessed by the criterion of their health impact as well. Because also environmental policies, occupational policies, for example, educational policies have a bearing on health outcome as well, and this is also confirmed by the empirical literature in health economics. So last but not least, I haven't talked about the labor market shortages in healthcare, which is also a very crucial point for the development of the health systems in the future and for their good performance as well. Ladies and gentlemen, I thank you for your attention, and I'm looking forward to questions and comments from you, from the audience.
Thank you very much. Indeed, we have already received 2 questions, so let's start with the first one, something that you kind of answered, but I'm still going to ask that. So could you please elaborate why the Ministry of Finance has developed a department for healthcare analytics? What is your department's contribution to the healthcare policy?
So from our point of view, the sustainability of the health system, the fiscal sustainability of the health system is important. And so we are mainly occupied with the cost side of the health sector. And that is the reason why the Ministry of Finance is involved in healthcare analytics. And it's particularly important because a part of the Swiss healthcare system is financed by public finance, by the taxpayers. And this is the reason why we are involved.
Sounds perfectly reasonable. Now, how to select correct and find meaningful indicators for healthcare outcome measures and incentivize their clinical recognition and adoption?
Oh, this is a quite general question. Regarding the indicators, I think the OECD has developed really some very good indicators on this issue, such as, for example, the avoidable mortality rate. Also, there's also an indicator which tells you something about the unmet needs of a health system, which are indicator where you can, from this indicator show how well the healthcare system performs. And I think there are some indicators already around from which you can gauge how you can assess your health system.
Rauno asks, what is the reason behind the decline in health spending in 2022 seen in several countries?
I think it's the effect of the pandemic, because during the pandemic, healthcare expenditure have increased, and as a result of this, after the pandemic, there was a normalization of healthcare spending, so to say. This is the reason.
And the last question, Estonia has a new government. One of our new ministers is about to step on the stage. What is the one recommendation for the government to prioritize regarding the interrelationship between healthcare and the economy?
I think one of the most priorities would be to focus on health outcome in particular, because in Estonia you have still comparatively low level of healthcare expenditure in terms of GDP from my point of view, and therefore I would prioritize focus on health outcomes. So make the health system more that you should increase the health performance on the one hand, on the other hand you should also look for measures to improve the health efficiency of the system.
Well, more questions are coming in. I'm afraid you can't leave the stage quite yet.
Okay.
We still have a few minutes left. So how has Switzerland balanced private incentives and societal goals?
In the healthcare sector?
In the healthcare sector, yeah.
It's difficult. That's a quite challenging question. But I think in the healthcare system, the healthcare system is very complex, and you try to merge on the one hand, private incentives with governmental regulation. And how we have managed, that's difficult. We have, on the one hand, providers have very much leeway in Switzerland. I think, and this is good for the incentives of the providers in Switzerland, for example, for general practitioners or specialists in the ambulatory care sector on the one hand. However, there are also disincentives or wrong incentives that leads to too high spending, to inefficiencies in the system at the same time. So there are positive incentives and negative incentives at the same time.
It seems we have one last question. What has brought most success in your work towards Swiss healthcare systems?
I think to make the cost development and the reasons behind it, the structural factors which bring about the continuously growth in healthcare expenditure more transparent.
Thank you very much.
You're welcome.
For a great presentation. Thank you. Dear friends, we'll now move to our first panel discussion where health and the economy literally come together on this stage, and I will be left to listen and to ask questions. Now that we know that healthier people generally contribute to economic growth, and this is, I guess, something that we didn't really need the data to prove it, but now that we also have the data, it's great to follow up the conversation from here. Let's see how those economic policies actually also shape our health policies, how they contribute to healthcare financing. And I'm pleased to invite onto the stage the Minister of Social Affairs, Karmen Joller. With your applause, ladies and gentlemen. And the Secretary General for Economics and Innovation at the Ministry of Economic Affairs and Communication, Ahti Kuningas. Please take a seat. So, Karmen, what would help to change this mindset that we still often meet with, that healthcare is merely a cost, especially, I guess when you look at it from a financer's perspective. Oh, another percentage to healthcare. Can we actually deal with less costs here?
I think one way to change it is for a Minister of Social Affairs to speak of it. So, and also the politicians, we all must understand that we need healthy people. Actually, I think, especially after pandemics, the world has more and more thought of it, because we have seen huge economical decline during pandemics, also because of the costs of healthcare. And not only costs, but also because people could not work, they could not move around, and so on. So I think the world has had to recognize it.
But now that the crisis is over, we turn back to the so-called normal operations, normal life. Do you see that actually this connection, that every euro that you invest in healthcare actually brings back economic benefit, that this broader understanding is there? And do we also have the data in Estonia to back it up?
I think we have all seen it, but we don't speak of it a lot. We don't have a good data we have some data in Estonia, but not very good one. We have some estimates, for example, about mental health, and also, well, we have some data in kind of certain diseases like obesity or and so on, but we have not estimated it very systematically. And actually, I'm happy to meet you here, Mr. Kuningas. Yes,
well, finally you meet, right?
Yes.
Finally, it's the time to have
Exactly.
this difficult conversation.
Yes,
Yeah.
I became a minister for 7 weeks ago, and since then I have wanted to talk about the way of thinking that health should not be only a cost, it can also actually be benefit.
Thank you so much for the Swiss ambassador for
Yeah,
making
thank
this
you.
meeting possible today and
You
to
do-
really have this discussion. I believe it helps if you also have a microphone so you can respond and actually be in this dialogue. Now, Ahti, do you have the evidence that we've been talking about, that every euro invested in healthcare actually brings better return to the economy, be it through reduced sick leave, better productivity and innovation, or is this an abstract conception that we, in a way, understand that it might be theoretically possible, but we don't really have the data to prove it?
It's not abstract, but yes, we don't have data to prove it, at least in Estonian context. We haven't looked at only from cost side, we have looked at also from this benefit side. So if I take 3 pillars, then we have covered 2. One is this where we have prioritized some areas, and medicine one of them, but then we look if somebody conquers foreign market or makes a new product. Second one is labor issues. Now a bit more than a year are in our ministry. So here we also looked at a lot of people who are sitting home, whatever the reasons are, but mainly health reasons, that they at least get partially back to work because what resources we have, I don't know, energy, raw materials, and then people. So we have to get the last bang out of most of those. But yeah, this general health and how it affects the economy, at least from our house, we haven't found. And I even just looked for general data, then was this golden productivity age from 1945 and up to 1980, which we missed, of course, with some obvious reasons, but mainly the reasonability has been that, okay, Marshall Plan and industrialization and electrification, but actually there are few studies that one of the main reasons is health, that something, average age went up 10%, actually healthy lived years 20%, and vaccination, which was the cause of those 2 first ones, more than 100%. So yeah, it has been actually one of the main pillars of this productivity growth, where we are now stalling.
But what are the impact assessments or additional data that we actually need to make a stronger link between every invested euro in our healthcare and, well, hopefully a great hike in economic growth? Because I think we have a lot of data in Estonia, right? Most of our systems are digital, the databases are connected, they can be scanned through, hopefully with big data analytics as well. So what's actually missing? Is it just a political incentive to, well, look at this data, or is this data unreadable, or where do you see the problems, Ahti?
At least from our house, yes, we look only these economic outputs, as I explained. I think all the data is here. Either medical data, which of course should be anonymously categorized and put together, and all the working health and working age data we have, and I think we just have to put it together. There hasn't been this kind of ask from our ministry.
Wouldn't it be a wonderful argument to increase dramatically healthcare spending if we looked at the data, saw the results, every euro that you put in, you get economic hike back?
I will bring you the data, please give us money, yes.
This conversation already reached its final goal very, very early on. But more seriously speaking, I mean, what do we need to do to actually get a clearer picture of the long-term investments that we will clearly need anyway in our healthcare, looking at the deficits and the return in economy, to really make that clear for the policymakers as well, that, okay, this is something that we should consider?
I can tell about the data.
Yeah.
We actually have very simple data, and it's collected all over the world. It's how long we live and how well we live. What is the expected lifespan, and for how many years are we able to be healthy and useful to the society. And as for Estonia, we actually have had a very, very fast increase of the lifespan. Actually, it has been the fastest in the whole European Union. But still we are, well, actually, what we have done, we have not increased the years where we are healthy. Instead, we have increased the years when we are sick. It's paradox, maybe, because if we live longer and we don't improve the health, then we actually live longer being sick. And this is a higher burden to a society and also to the economy. And therefore, we actually should see where are the what are the main reasons we are sick. In Estonia, and actually it's worldwide almost, well, in Western world, it's cardiovascular diseases and also it's cancer. And of course, the lifestyle, which has its effect on both of those disease groups. So we should focus on prevention, on cardiovascular diseases and on cancer. It's, if I take it very broadly. And if we
This is where we spend the money.
Yes, yes,
basically.
we should. Yes, we should target these issues. So when we start, when we achieve the decrease in those diseases, maybe we will increase the years when we are more healthy, and then we can contribute to also work. And actually, when you asked what should be done to change the mindset, actually, employers have been, at least in Estonia, the ones who have spoken the most that we need healthy employees. And they also really do a lot to make them healthy, but also they need help also from my house. So what I'm going to do, I hope so.
We're actually going to have the employer's representative, Hando Sutter, on stage soon, so he will elaborate more on this. But to come back on the policy perspective, now there's this idea, health in all policies, right? This conception that you should actually consider the healthcare aspects in basically everything the government does, right? Now, for it to become more than just a slogan, what's the first structural change that we actually need to make? Is it like between ministries, or is it a question in leadership culture? Where do you see, how do we move to this health in all policies approach, Ahti? And do you see it reasonable?
Yeah, I see it reasonable, and I think a lot has changed with the last government. And I'm not just being modest. Because ministries are living in silos, and the Ministry of Finance is also soon here. They are redistributing money, and actually they always try to do their best. If we show with some new project that the return on investment is good, then it's possible to get new funds. Of course, right now, when there's defense is the priority, it's more difficult. But why I was mentioning the new government is that there are some projects which are all over the ministries, like taking down the bureaucracy, and then also economic issues, which are every other week in the government. And economic issues, yeah, I'm from economic ministry, but this is not only our people who go there, all people go there with their different projects. So this kind of one leadership from state chancellery, and also politically prioritized topics actually bring people together from the different ministries. So far, yeah, every ministry is with other topics in kind of silo.
When you come together with discussing how to basically make the economy grow again, do you also discuss healthcare and healthcare policies, or is that somehow left on the margins?
It's been only a few months. I think if there's some kind of value in it, then we come together, yes, of course.
But not yet?
Not yet, yes.
I told you it was the first meeting here. Yes, but as for economic growth, we actually, when I mentioned prevention, in Estonia we have huge problem with alcohol. We are one of the top alcohol consumers in European Union. And for example, when we have considered alcohol policy, it quite often collides with someone's interests in economy.
Well, one minister didn't do too well when he tried to dramatically raise alcohol tax.
But the tax is only one little part of alcohol policy. Actually, we have also on table some measures that we should take. Also to, for example, limit the times we sell alcohol or the places we sell and so on. I have not reviewed these measures yet, but if I find them to be scientific and evidence-based, then I'm sorry, but then I will probably have problem with you and your ministry, who would like to protect interests of some alcohol distributors or producers. So it's an ethical question actually, and also it's a question of vision if we, and also question of balance, because it's not my interest too that some kind of producers or distributors would be bankrupt, or I don't want to take off anyone's business. But at the same time, by profession, I am a doctor, and I cannot tolerate when my people are killed because of bad policy. So it's one of the many examples, actually. And yes, of course, health in all policies is a very important principle, as health is something we actually cannot directly buy with money, but indirectly we can do it.
Today is a lot about data, the digital assets that we can rely on in designing better policy. Now, in your view, what is a bigger problem that we currently have? Is it lack of usable data, or is it the poor organization and the structure of the healthcare system itself? And if it's the latter, then what does this poor organization of the healthcare system actually look like? Carmen, this is something that we also discussed before the event.
Yes, we have a lot of data in Estonia, and I cannot say it's very poor, because we still are one of the leaders in the world in digital government and so on. But of course we can do always better, because our digital data started to evolve about 20 years ago, and some principles how the data are collected or where the data are collected to are from that time. So we have to update the way we collect and distribute the data, and also the rights on data, the data protection. In Estonia, data are very, very protected. In healthcare, data is owned by people, the persons themselves, and the government has no access to it. So
is that a problem?
It is a problem, actually. It's,
what do we do to actually change this?
We are going to change it a little bit. We give the people the opportunity to give active consent to use the data for science and for analytics too. Because, for example, we have different databases. Now we plan to unite them in healthcare, so that also health insurance fund can have better analytics to see where the finances are maybe too much or maybe too little. So we can start guiding the services in healthcare through usable data.
This is very interesting. Can you be a bit more specific already about those plans? What databases do you see the need to connect, and do you have a time frame for that?
Yes, for example, we have a health information system where all the data of your disease is stored. If one visits a doctor, the doctor writes something and then it's stored in health information system. The other database, for example, is a database of prescriptions. And there is also a third database. What was it? I don't remember. Genes. Well, genes is already fourth. So we want to make all those databases to communicate with each other. And as for genes, we are we actually have the first law for gene database in the world. We update it now so that the people who have given the samples of blood for extracting the genes, about 200,000 people, and we give them, as I mentioned, the option to give a consent to be part of science, for example, or any other studies, so that, for example, pharmaceutical companies can have those data to develop better medicines.
I mean, I can't wait until I get personal recommendations, not only by my gene analysis, but because I have a smart device measuring my sleep statistics, my everyday movement, my stress levels. I guess they're pretty high right now, every single day. If all of that data combined with my doctor's blood analysis that I've given, which shows slightly higher cholesterol levels than I would like, could that all come together in a genuine system where personal recommendations for improving my health actually come to me before I get my first heart attack, which will be very costly for, the whole society?
Actually, this is a philosophical question. At first, I also cannot wait for this data to be visible for everyone in a certain way. Actually, every Estonian can see the data, as you said, all the cholesterol levels and so on, but the recommendations, the best recommendations for your lifestyle, you get from your plate and from the scale in your sauna or bathroom.
They don't always reach the brain. That's the problem. And even if they do, then they don't always materialize in a change of lifestyle.
I'm sorry, but the data...
Perhaps if my doctor really looked at me in the eye and said, Johannes, do you want to have a heart attack in 5 years? And
do you want to have a heart attack in 5 years?
No, I don't. But if my doctor confronted me with the fact that I will, if I don't change something, maybe it's more efficient than just looking at the scale.
Well, we as doctors, we do it every day. So, yet we have high heart attack rates. And we have, as a motivation, we can use data, but we never ever can replace it, personal's own responsibility. It is always the first thing. As a doctor, I can say that the best way to make you rethink your ways of life is to use motivational interviewing. It's a special technique we use on patients. This makes you believe that you made this decision yourself.
Motivation is slightly growing already, but actually before we reach this dream scenario where all the sensors and all data comes together to personal health recommendations, we actually need to fix the issue with different already there databases that still don't connect with each other, right? So if you go to one hospital, they have their one database, another hospital has a different one.
Well, it's not in Estonia. It's,
No?
well, we see it.
Do we have all the data available for
We
the
have.
general practitioner that they see everything?
Of course.
Okay.
I would not trust you.
I trust you. You know better.
Yeah,
than
I
me.
wouldn't trust to treat you other ways if you were my patient. I'm happy you are not because you're healthy. You look healthy. So, so we actually have all the data. It is not presented in a very comfortable way.
Is it machine readable? The data?
Sorry?
Is it machine readable?
It mostly is, but not always. Mostly it is. We have worked with this for years by now, and I hope that those recommendations you tell me, you talk about, will be visible quite soon, because we are right now developing it. I don't know the pace of the process, but the recommendations, I'm afraid, will not be in your brain. You need your inner motivation, anyway.
I'm listening to Carmen, and it seems that we have a lot of data. Most of it might even be machine readable. If we have that data, if we have your smart people who can build algorithms on top of it, do we see a future in Estonia where we look at the data sets, we look at where we spend the money, we look at what we need to fix basically to have better economic outcomes? Could that be a thing that makes you interested in to see, okay, what if we do this and that? What kind of results will we have in the economy? Is this something worth looking into in more detail?
I think we are both interested. I leave this expertise still to the right ministry. But talking about data, yes, we have a lot of data, but we have legacy regulations, and that we are changing. We have this one department in our house whose motto is making illegal things legal. It's not money laundering, it's what is today illegal. And actually, there are, I think, seven, 8 different health-related projects. For example, this is not about data, but a bit as well. Like pharmacies, 24 hours, like parcel machines, how you can contact your the right person, you get your receipt, medicals also at night. You don't have to go to emergency, for example, but at the same time with face recognition and the person behind the screen, you can be contacted. But so far it's not legal, so these kind of projects we look to make legal, but also with different consent issues and connecting different databases that, as I understood, sometimes it is that, yes, my doctor can look my data from another database, but I have to download it and forward it to him, not that if I give a consent, then he can actually take it directly. So yes, this kind of legal changes what this unit is doing. But especially all those what you wanted, that
well,
you see
dream.
this should be left to private entrepreneurs. We should just provide them data protected data and consent based data.
That's something that you're considering and preparing for private entrepreneurs to actually get access to that data and build services.
Of course, yeah.
Well, okay. Thank you, dear audience, for your questions. I see them coming in. Carmen, I guess the first one is for you. You just started the work in the new government. What's your vision in 4 to 5 years? Which are your top 3 priorities in improving healthcare?
Yeah, it's a very good question. I actually have really top 3 priorities. First, I'd like to reorganize our a network of healthcare providers so that if someone needs any medical help, they would quite nicely know where they should be, or that they would be at the right time, at the right doctor or specialist. Sometimes, or quite often, the specialist doesn't have to be doctor, can be also nurse. So one of them is to reorganize the network. The other is to improve quality systems, because we have many different qualities, and we have also healthcare providers who actually don't have proper quality system. So I would like to have all over country a similar system, at least in big perspective. And the third is, of course, what we are talking today is the financial problems, so that we would like to review the financing of healthcare and also consider how we can have healthcare not only a cost but also benefit to country, and how we can give out the message. These three things actually are very big things. So I don't know if the vision will be in 4 and 5 years. If I can do something of it, I would be very happy.
Well, we saw from Karsten's presentation that Estonia, spends or invests is a better word, invests in healthcare comparatively little with our neighbors, the countries that we would like to resemble ourselves with, let's say, the Western European countries who spend the percentage of GDP much more than we do in Estonia. What is, do you think, a realistic scenario here? How much can we actually raise our investments in healthcare, or does it these days only go to defense?
In Estonia we spend 7%, and the average in the EU is 9%. So
we're lagging behind.
Yeah, we're a little bit behind, yes. But the data also shows that for this 7%, our quality of care is very high. And still, I see and I know that we can spend the same 7% a lot more better. We can improve these three things I told in the last reply. If we improve those three things, we will start using those 7% better. And when we use them well enough, then we'll see, maybe we will try to increase also the investment. That would be welcome, of course.
It would. So if we look at the private sector, Ahti, you briefly already mentioned it. What is the role actually in Estonia that you see that the private sector in healthcare should take in order us not to completely override our system that is still based on solidarity, that is still based on taxpayers' input? Everyone who's in the workforce should have free access, basically, to the healthcare system in most services, right? So what is the role of the private sector that you see that could actually balance the deficit that we today have in Tervisekassa, for instance?
There are, again, very different approaches. First thing, what I would mention, that new kind of services, especially, I think Estonia has huge potential since we have so much data which has to be actually systemized, and then to build all kind of services, what you mentioned, that very personalized recommendations for you, so that the people who sometimes go to esoterics, actually they want to just some kind of relief to their problem. They see that this is a sugar problem. For the brain fog, I'm stepping out of my specialty, but yeah. But
it's fine, I do that today a lot, yeah. You can do that a bit too, it's okay.
So if they can see there are some kind of future solutions and some kind of very good recommendations, I think this, and why it's very interesting time right now is this AI. I'm not talking only about this huge AI machines, but also specialized programs with very specialized data, which are not expensive at all, or even really more narrowed, very specific topic, which are actually for pennies nowadays for development. This is one pillar. Another is, of course, all the enterprises, I think even ministers and at least large enterprises, we look at the health of the people very everyday business, spot compensation, but also assessing mental health, which is getting worse, especially for young people. Then I would like that all the question for me was asked actually by employees that would you add this massage to it, and actually in our management we decided that not massage but this physiotherapy, because this is at least solving something for the future. And then of course a lot of companies, and we have assessed but not done it, is combining the public insurance with this private insurance, just to detecting the problem as soon as possible, not to carry it to the future.
Carmen, similar question. How do you see the private sector, and if you see the private sector playing a bigger role in Estonian healthcare system? It is a difficult topic that is not always discussed in Estonia without a conflict, but let's try to imagine that the private sector could play a bigger role. Could it, and what kind of?
I don't see a very big conflict if it's done wisely. In Estonia we have quite high percentage of what the people have to pay themselves in medicine. Again, it's one of the highest in Europe. It's 22% of all expenditure. And in these areas where the people have to pay themselves anyway, we can use the benefits of private sector. But we have to see it also, as you said, it usually causes conflict. It is because some examples from other countries have shown that if we use private sector, the prices are going to spiral up. So we have to find again the balance where we can use the private sector and private doctors, and where we can not use them. So it's a matter of discussion, and this discussion I will start with scientists, doctors, and also the private sector.
But for instance, employers. We're going to have Hando Sutter on stage soon. What do you think is the role of employers in the long run in Estonia in keeping their workforce healthy, which they obviously are very motivated to do?
I think it's enormous. But actually the way how employers see, the way how they benefit or give benefits to their employees, it sometimes is based on beliefs, but not on science. So again, we have to discuss what are the factors that could be changed. For example, it's quite, as you yourself told, that if you go to doctor and doctor tells you that you should change your lifestyle, it somehow is of better effect. Actually, it has scientifically proven that the maximum effect usually is 6 months, and that's it.
Then I need to go to the doctor again in 6 months.
Yeah, so that the doctor would tell you, aye.
You didn't change anything, Johannes.
Yeah, exactly. So, or you did too little. So we actually should find the ways that people really have this inner motivation, and employers can do it. They can create a more healthy environment also for mental health, not only physical health and so on. Employers actually know it very well. They can tell you themselves what they do. But visit to a doctor, it doesn't have to be the way to improve the health, but it is a popular view.
If we talk about digital innovation, then this is one of the ways that we could actually spark economic growth, right? We start developing new platforms, new health apps, systems, whatever. So, Ahti, I don't know if you've thought about that. Are there steps that the government could actually take to create more public-private value in healthcare and in digital health innovation? You've discussed some ways that you want to improve it, but what else could we actually do to get the private companies on board, and should the government somehow support this? I don't know.
I can answer also.
But-
You can
but
do it.
let's start.
Yes, it's very easy. It's because, for example, if we start creating our digital systems, we can give some parts of it to be developed by also private companies. We don't have to do it only by government. Because
Hopefully not, because the government isn't
it's
the best
slow.
project leader
It's-
as well,
Well, not
in
government,
many cases.
but the ministry or yes,
Yeah.
But and actually the COVID, the pandemics showed that private sector can be really of use, especially in digital development. Well, we had some systems lacking, and some businessmen came together and did it within 1 weekend. So it is a very good example of innovation.
So the healthcare system needs to open up more for this kind of
I think so,
private
yes. And
innovation.
plus this can be an article for export.
Right, Ahti, health tech, big thing?
Actually, I can say that it's because of money something is not done. Because in Enterprise Estonia, as I said, one of the 3 specialized areas is healthcare. Whatever, is it biotechnology, is it personal medicine, is it data in medicine, you can apply for all the programs. And from 100,000, even less, to 2 million for different R&D projects with medical institutions or universities or your personalized projects. This is one thing. Another thing, what I said in our house is this, we are making illegal things legal, that we're looking over the regulation. And then also in startup or venture capital, we are providing money to this healthcare. So there is money in the system. It's EU fund money, and so probably it's going to be next period as well, even we are cutting.
I see the audience still wonders why those cabinet meetings dedicated to economic growth that started in October, why hasn't healthcare been discussed so far, as it affects the economy considerably? Ahti, do you know the answer, or government?
I can tell that since March, when I started working, we have discussed healthcare too.
So it's been on the agenda.
It's one of our priorities also in government.
Okay. What are the steps the Ministry of Social Affairs will take to battle high cardiovascular disease death rates? Very specific question.
It's very, and an answer is also very specific. Please lose your weight and walk more. That's the best answer.
Responsibility for the person. We wouldn't have that problem if people were responsible
It
now,
is,
would we?
Exactly. People are responsible for those two. But as a minister, what I will do, what I already have told I would do, is the 3 pillars of its financing, quality of care, and also restructuring the network of hospitals and clinics.
More questions from the audience coming in. Healthy society contributes as labor for economy and builds resilience for defense. How ministries of economy and also defense can contribute to people as strategic resource? That kind of a question.
Oh my God.
It's
First decipher it and then answer it, please.
Yes. As I mentioned, that all the people are valuable, whether they are. So we are very much concentrating on this, that they are not sitting at home, they are coming back to work with this employment agency. They are not too long at home that they wouldn't come back, and even if they do part-time work, it's good, or several part-time work. So yeah, I think this is one large part of the healthy population as well, that if they are home, if they are not working, then they are not mentally right always as well. So yep. Can you
Carmen, do you want to add something to that?
I think you said basically the most important things, but in general, if we need defense, healthy people can defend much better than sick people. So it's quite a rhetoric question, I think, because we all agree that we need healthy people, not only for defense, but for everyday life and just for being happy.
And the last, not the last question, one was just added. I wanted to say the last question from the audience is, what is the plan for the government to measure societal value of healthcare services, pharmaceutical, digital devices, etc.? Something that we actually started our conversation with, but perhaps this is something that needs to be answered again.
You want to answer?
Everything should be, of course, measured, because like we measured, sometimes it goes in campaigns. We measured very well these environmental issues, that how everything is affecting something, and all the ministries even were detailed. The same thing what we have done in our ministry, because it's our responsibility now, is with gender equality and how it affects the economy. But also health should be measured, and the main thing I think is education in different levels of the economy and different ages. This is the main reason usually for all the areas. This should be measured as well.
Yes, in healthcare, as I started, we can measure how long we live and how healthy we are. It's one of the options. But what we plan to do now, again, it's one of the 3 pillars, quality of care, and there are very, very certain measurements how we measure quality in medicine, and we'd like to use it in Estonia. Better way.
As we are running out of time, and that little thing over there is blinking with a red light and shows zeros, I think that usually indicates that time's out. But one last question. What could be really the next concrete steps to make health and economic policy work more closely together? Because, I mean, the best outcome of this conversation would actually be that you go back to your ministries and well, things start happening. So what are the 3 things, Ahti, that you plan to do to make economic policy and health policy better aligned?
I mentioned the money has been there, but the main thing I think is look through regulations. What we are doing anyway right now, just some old things to demolish, but also when we have somewhere legacy where we can't use data, then these things should be looked through, and then the private sector does its job very well, better than us.
Carmen?
I will meet with Ahti's boss, the minister.
That's the first step that covers all the next steps?
Absolutely.
Carmen and Ahti, thank you so much for this conversation, ladies and gentlemen. They deserve an applause. Dear friends, we are going to continue with a next debate, our next panel discussion, and we're going to look at a very important topic, right? Estonia's health insurance fund is running into, well, what I would call as a journalist, serious trouble. Perhaps there's a better way in describing it. The budget gap for next year is more than 200 million euros, and by 2027, I guess we might run out of reserves completely. Now, at the same time, We see that the state budget is under pressure, so there are no easy fixes. But perhaps we can turn this problem around and somehow find a good solution. So we're asking now in this panel, how can we rethink healthcare funding, not just to fix the gap, but actually to build something stronger and more sustainable. And to answer that question, I'm pleased to invite onto the stage the chairman of the management board, Estonian Health Insurance Fund, Rain Laane, and the Deputy Secretary General of Fiscal Policies from the Ministry of Finance, Sven Kirsipuu. Rain, first, what are your 3 top arguments to the Ministry of Finance when you meet Sven? You clearly need more funding for healthcare. What are the arguments that you normally put out?
Good afternoon. We know Sven, each other, we know quite a long time, and we know also that there is money outside somewhere. I met a few weeks ago my Lithuanian colleague. He was in Tallinn. And he told that in Lithuania they ended up last year, health insurance fund, ended up with a surplus. And I can't say that they have plenty of money, but it felt like this. And then he said, and then Ministry of Defense Lithuania came and said that we will collect all your surplus.
That's the example that you give to Sven?
No. Wait a second.
That's not a good example, Ryan, to get more money.
Johannes, wait a second. And then I asked that, how did it happen that you ended up with a surplus? Because was it wrong budgeting? Because we all are suffering and there is a lack of money. Healthcare has 2 situations of money. Either there is a little money or no money. And then Gintaras said, well, Ryan, look, economic growth. If you would have economical growth instead of negative growth, then you wouldn't suffer. So my first discussion with Sven is when we are going to change the economy to grow, and then health insurance fund, we are funded by all our taxes, and then we will have little more money, and then we can spend it wisely.
And get even more money?
Johannes, you began the story that which we all know. Good thing is population is aging. Not so good thing is that around those people who are working in the ages of 20s, 30s, this number is decreasing, which means that the moment when we reach there, then all young people who haven't born yet, they have to basically work 4 times harder. That's the challenge, which means that this is not the doubt that we would need in the future more investment to the healthcare. But we need to find a way how to do it. Carmen said her 3 priorities, and we are going to discuss soon what we are going to do and what priorities we see also in health insurance fund.
So Sven, what kind of evidence do you actually need to feel confident that supporting a stable and long-term increase in healthcare funding actually makes sense?
Yeah, I guess it's not a question about growth or whether the growth should be there. Growth is always there if the wages are growing. But for example, my first question would be, although the economy is not doing that great, the wage growth has been still quite high. So the revenue from social tax has increased by 50% in the last 5 years. Where did it go? So this would be the first question, but it's of course a simple question, but at first glance, but it's actually more difficult to answer, because if we're talking about structural changes within the budget, within your budget, then there are even more questions. If you're discussing about sustainability, then we can ask the question, how can a system be self-sustainable if large components of your budget are growing faster than the country's average wage? For example, the wage bill of doctors and medical staff. So, if there are no internal balancing factors that roll back the expenditure growth, then there cannot be a sustainable system. So the parallel would be the system, the pension system, right? The pension system was tweaked in a way that there are internal balances that roll back the growth if, for example, the life expectancy increases. So these are the questions that we have, I guess.
You asked a difficult question and then partly answered it yourself.
If I may add,
You
or answer. A little bit looking wider picture, because one thing is economical part, how well we are doing. And this is not a secret or big secret that, that Lithuania is doing better than Estonia last year. Don't worry, we will catch up. We always did. The second part is the fact what we know that the euro or dollar invested to the health promotion and disease prevention will bring you back $7 or the treatment is $7 more expensive. And that starts, I like when Carmen said, it starts from ourselves, because nobody else can change you beside you. And guess what? I'm doing already quite a long time morning exercises, which I hate. I'm the night person. And when I wake up in the morning and see that I need to go to the meeting, but no, I need to do my blank. And this is not easy, those who have done, but keep trying it. And persistence is the key there. Educational part is the key also in healthcare. The more educated people in the country is, the more healthier this country is as well.
Brian, I understand. I don't want to bring this drama back, but it does seem that the current funding model no longer allows you to maintain...
We need to change the funding model, fully agree.
Yeah, so the current model no longer allows you to maintain service levels, is that right? So what exactly needs to change?
Okay. In Health Insurance Fund, we are currently preparing the next 4-year strategy or strategical document, our development plans, and there are 3 main parts. Our lifestyle needs to be changed, otherwise we will not survive. And to do that, when we look our primary care, the situation in our primary care when we have roughly 800 GPs, general practitioners, both solo and with working together, 300 out of them are at the retirement age, which means that if we push either too hard, then 6 months later we have 1/3 GPs less. And then we can't handle it anymore. So we need to fix that one. We will try different models. We will use a lot of technology as much as we can, both to make sure that right people, right doctor, right specialist, right time, etc., as Carmen said, that we are going to use. Second one is priority is the changing the financial model of the healthcare, and we are aiming towards the value-based healthcare, meaning that we need to start measuring way more the health results than we do it right now. We have started several years ago the patient treatment journeys, and where we are measuring the PROMs and PREMs, patients reported outcome measures, patients reported experience measures, and this is only 1.5% out of our whole treatment budget. When I would say that, okay, let's increase this 1.5% to 5% or 10%, then politicians are saying, no, this is a too low goal. But in reality, it's a very ambitious goal. So that is the directions where we need to start moving. And the third part is, which already discussed today, is to fix all the data. Because you cannot make decisions looking the mirrors. What happened in the past, we need to see the future. And currently we have 3 major databases which we must connect. Because data is there, and legally we cannot check 2 or 3 databases at the same time. We have plan, and luckily there will be a change of law, and then technological part we are going to do ready by the end of, I would say, this next year. And then we see how fast the legal challenges are going to be solved. So these are the 3 things which we are going to do, and of course what Carmen said about quality, that's essential. That's essential thing in healthcare, and that you cannot check if you don't have data. And also quality part, I personally don't think that when you follow all the written steps that you necessarily provide very quality work. You might, but not always. I would love to ask feedback from the customers. I would love to compare the treatment results, and this is where we have room for development.
So, Rain, what you basically said, right now the funding in healthcare is mostly based on volume. Who provides
fee for service, and
fee for service, exactly.
This model doesn't attract the service providers to make necessarily the better work, because if we pay based on volume, then they increase volume.
So how do we make that shift? I mean, clearly no one wants to offer less services without a good carrot to offer those services more effectively and to get, well, a reasonable amount of money in return, Sven. So where do you see that tension, in a way, that this volume-based healthcare financing has, well, brought us today where the system is not, well, capable of continuing in the same path?
Yeah, I guess as I'm not a healthcare expert, I'm not sure how I can discuss about the sort of internal incentives or what incentives work the best within the system. I see more the macro level imbalances. And as I mentioned, this is the question of sustainability. And if you ask me what should we do, then the first question comes to my mind: do we understand the problem, or do we understand it the same way? Have we decomposed the issue of unsustainability? Where does it come from? Are there internal balancing schemes in place, or should there be internal balancing schemes? And of course, you within your sector, you can discuss how to more incentivize the hospitals and the sector to provide better services and perhaps more efficient services. I don't know. But this is, for me, more of a question of results rather than the financing. So looking at from the financing perspective, the first question is, do we understand the problem? Are there internal possibilities to fix it within the system? And then we can arrive at the questions of whether we should invest more in the system to get more social sort of benefits.
So and what you're saying is basically, should we shrink the system?
Not necessarily. I mean, I didn't touch upon the effectiveness of the system in terms of the hospital network, for example. So these are also questions unanswered. What is the impact or possible impact of restructuring the healthcare system in terms of hospitals and in the regions? So this is another unanswered question. So we have to put these puzzle pieces together, and there has been a discussion that a lot of data is available. The data itself doesn't speak. You have to have a narrative, you have to have arguments. The more data you have, the more difficult it becomes to understand what is actually going on. So, and then we arrive at how the budget decisions are made, how the financing is made, and the more data and conflicting data you have, it's much more difficult to actually introduce additional funding to the system, because there are no clear answers or clear narrative or clear objectives.
Right, you obviously have looked the data very carefully.
Yes, 2 comments. Sven, I agree that data is a key, and we have pretty strong analytics department in Health Insurance Fund. I have to tell you a story, and then you understand better the challenge which we have. Story is very simple. When we looked from the data where the time disappears. The time disappears when you go to the outpatient meeting, and either GP or the doctor spends 20 minutes is a FaceTime towards patient. And out of 20 minutes, 15 minutes, doctor is typing in a computer and putting the stuff there. And we thought that because I have passion for technology, and we thought that, okay, let's use IT and to get people more time, both doctors and both patients, and then there is a fabulous thing, artificial intelligence. And imagine if AI would make an epicrease instead of doctor. You don't need to type, you will look the patient, and everything looks really fine. We do quick mathematics, okay, we can give you, they're doctors, we can give you 10 minutes time out of 20 minutes appointment. And then as a businessman, we thought that, okay, 10 minutes time, we can multiply all the visits, we can heal all the patients, but demand is endless. And then I had a meeting with the Doctors Society, and I asked the question, what would you do if you would get 10 additional minutes? These are not private doctors. These are government and local municipality owned hospitals mainly. And there were like 200 people. And they almost unanimously said that, thank you, please give us 10 minutes more time. We will use this 10 minutes to talk more to the patient, and if there is no need to talk, then we will use this rest of 3 minutes, 5 minutes, 7 minutes to heal our mental health. And then I realized that, and I asked the same question while I met private doctors. And then we got the answer what we thought or we expected. I will take another patient. And there is a huge difference of mindset of thinking. I'm not saying one is wrong or one is right, but you might think lots of ways how to improve things. Unless you are not piloting or testing or speaking with the audience, then you might be totally wrong. And then we realized that we are totally wrong. We did the project, which idea was to make people's lives easier, that you can do the blood test at your village or your area where you live. You don't need to drive to the hospital. We did this project, and our execution was bad, because hospitals still are saying that you need to come here and you need to give this blood in our hospitals because the payment model is wrong. And unless the payment model is wrong, then they are not going to change, because there is no motivation to do that.
So, Ryan, how do we change that motivation? I mean, clearly there is not a lot of enthusiasm to go to this outcome-based financing model, right? So what do you do to get them on board?
There are 2 things. There is always 2 motivational things.
The stick and the carrot.
Stick and carrot. And we would love to push more on the carrot side, then carrot side, and then carrot side, until we have it, and then we have reached to the limit, and then we need to try also the stick part.
So where are we in this progress?
That is what we are going to do, and this is the first time in my career where I have a minister who really supports. Yes, Rain, you can use stick, because earlier ministers, they were more carrot type.
So where are we in this progress? Do you already have a stick with you in your office and ready to use it? And how will that look like?
Stick is there, but local municipality elections are in October.
Aha. Right. So we're going to see the stick being used after local municipality elections. What will that look like?
That you said, you mentioned, he said, not
yeah,
I.
what will that look like? How will you change the system?
We call it the strategic purchasing program. And that will help us. It includes both decentralizing and centralizing part. But I'm looking the watch, and we don't have time to cover it today.
Very briefly.
In October.
Very briefly, few keywords.
We need to agree with hospitals where we are doing which procedure. That's one keyword. And second one is that simpler services needs to be closer to the people. So, and that corresponds very well to the government statement that, what is the right word, for the health providers network, the right sizing, or right sizing is a right word in English because it includes increasing and decreasing, that's the same word. And also financial model changes, but it takes a little bit the law change, and that's I'm counting on the Ministry of Social Affairs and the Parliament, because without that one we will not move too far.
Sven, it's been a long monologue or a brief dialogue between me and Rain. I would like to bring you back to the panel so that you don't feel awkward and lonely on the stage. It is, yeah. How much are we actually using data to guide us where we invest in healthcare? And are we actually ready to shift our priorities when, let's say, new information becomes available and data shows that, oh, we should actually do things differently?
Yeah, I would start from the fact that there are a couple of windows during a year or during 2 years when these kind of decisions are made, large structural changes within the budget. One of them are the elections or the government changes, the coalition agreements, when things are discussed, hopefully based on data. And the other one is in autumn when we are putting together the state budget, when the Minister of Social Affairs has a floor, she can say whatever she likes. So you have to understand there are only a few points in the time when you can change something. And taking this into account, you better have to have good quality data, a good narrative, a good perspective, strong arguments, good ways of conveying the message. You have to have, the minister should have leverage within her party. The party should have leverage within the coalition. The moon phase has to be right. I have seen like crazy decisions made on crazy data.
It's difficult to control the moon phase, but do we have the data?
Yeah, we try to control the moon phase. We're trying to put the, you know.
Wow, you have a difficult job, but do we have the data?
This was a joke, but this is the question. We at the Ministry of Finance are relying on data provided by different sectors and different ministries. So, of course, we do not come up with the data, and we are not analyzing everything, but we are always suggesting that the better arguments and more quality you have in the data, the easier it is to overcome the moon phase or make the wrong decisions harder. Because if you're all over the place, then whatever can happen. But if there is a clear path and determination in terms of changing something, then there is a hope, I would say. But we have seen, of course, in terms of the changes in the budget structure in favor of the health insurance fund a couple of times in like past 10 years. One was the political leverage, like 10 years ago when there was additional funding put into the health insurance fund, and the other was COVID. So if something bad happens, usually it triggers additional funding. So this is also one sort of a trigger point, or you better have to have the data ready.
Well, in order to use this data in a meaningful way, we often face with rather expensive IT investments, right? Now, do we know what kind of efficiency and gains we're actually getting from these investments, or is this picture somewhat vague, Rain?
I respectfully disagree that all the IT investments are very expensive. When I looked at, we have done it not with the massive money there, and still there are plenty of things which are working and which is part of everyday life. Nobody asks questions how much it costs, because it doesn't cost so much. But we are getting immediately notification from the press that if something is under maintenance or doesn't work.
I do that, yeah. I call then your guys and say, why isn't it working?
Yeah. Like digital prescription, which is everyday life, and when this was before we moved cloud, now this is in the public cloud, and I sleep way better. While we did it ourselves, then it was down like 27 minutes, and then next morning I was on the morning TV, and they asked me, should we go back on paper because it's more reliable?
Journalists love drama, yeah. I'm sorry about that, but we do.
So definitely we need to invest more on IT, and I see the supportive council member in the audience who agrees that we need to put more money on IT.
So to do what? I mean, what are the digital systems that you need to make your work and the taxpayers' money, spending it more effective?
I can tell example of the connecting system from patient to the GPs. We call it PADI, the GP's registration system. And in the beginning, it was kind of suspicious part that easier was to call. But when 60 or 70% of GPs started to use it, and people realized that you can type there your challenge, and then this is like a triage that if you have severe situation, then you will be getting access faster. If you just need an advice, then you can wait 3 days, and it has picked up very nicely. And today, plenty of people are thinking, why didn't we use it years ago? But I see the great future, and what I rely is use of AI. Artificial intelligence is not replacing doctors, but can make life way easier, faster and smoother. And those who are not investing there, those are pretty soon living in yesterday.
What do you mean by AI in the healthcare sector in Estonia? What potential do you see?
For example, we are missing people from the radiology area, and those radiologists who are reading the pictures, machine can do it in some certain ways even better. And first pilot will be 2 doctors and AI, second one is doctor and AI, and pretty soon there will be only AI who are looking pictures. There is a legal, typically, I love lawyers, don't get me wrong, but there are legal questions why we are slow in some areas. Plus, connecting data, my best regards to the Data Protection Agency. So this is one of the projects where from the day one they said yes, they are supporting it, and now they can prove it that we can really go fast and realize that project.
Sven?
Yeah, just to add on AI, I think there is an imminent disruption in our way in terms of how we think about data systems, how we think about the software platforms. Because quite recently, SaaS model was the way to go, to think about it, put everything in the cloud, software as a service. So the projections from ex-CEOs of Google, for example, are that the middle layer of software becomes irrelevant. You only have data and AI that you can ask anything, which means that all these data systems or information systems that do some business processes become eventually irrelevant. So you have to have good quality of data and AI based on the data, and you can do anything. And this is not something in like 5-10 years from now. This is, the projections are like 1 and 2 years. And so we have to be prepared for that, or think how we can use it to our advantage.
We have...
Sven, you know that AI is a very rapidly growing child. And what children do, they sometimes, I can't say they are lying, it's not the right word, but they are inventing something. And AI right now, if it doesn't know the answer, it can easily invent that one, but that is what we need to double check.
Well, we even have stories where children kill their parents, but let's not get into those. Sven, you wanted to add something less dramatic?
Just one sentence from also a Google ex-CEO. I think he said that although we feel that AI is overhyped, he believes it's underhyped, actually, because we cannot imagine.
We don't know what it's capable for.
Well, isn't that an interesting discussion to go further into in the remaining 5 minutes we have, where I promised to take some questions from the audience. So let's hopefully spend those 5 minutes with your questions. What about tax reductions for healthy foods, exercise possibilities, and education? These things help people keep their health. Sven?
Yeah, sure, there are some tax exemptions in place in terms of healthy life, but usually the tax benefits tend to be inefficient in nature, because every taxpayer puts their funds into the tax incentive, and the people who have more money spend the more amount of these funds. So this is why they're usually inefficient. Of course, the other component is, does it change the price? Because the price is usually market-based, and usually the price don't go down as much as the benefits should suggest. But, and of course, there are exemptions to that. Some tax exemptions are efficient, but not all of them. Estonia has gone with a way of broad tax base, less incentives to keep the tax base or tax system simple, which has its benefits. But yes, there are some in place already.
What are the specific actions planned or ongoing in the health insurance fund while shifting from volume-based to value-based medicine? Do you have any examples?
Yes, to be balanced, then I will give two. One is a stroke project, and there is a positive results. So those service providers who are working together, they have got extra premium, and based on the results measured PROMs. That's a good example. Not so good example is the endoprothesis project, where we ended up, we just did it last month. We ended up that more than half of our service providers, they had to pay money back to us. It is kind of disaster, but it's a very educating disaster, because we agreed what should be the expected results. They didn't meet it. Some did, they got money, but majority didn't. They paid us back, and they will change something in their services in favor of patient, because in the end of we are measuring how patient is doing. So yes, we do have examples, good and not so good, and not so good we are learning, hopefully.
Aging, negative demography, conservative immigration limits, internal budget balancing. What concrete new financing sources could be attributed to healthcare? Who knows the answer?
Yeah, well, we in the Ministry of Finance look at the state as a whole, of the public finances as a whole. So the deficit of the health insurance fund is already a deficit of a country for which we borrow funds, right? So it's already within the budget system, and if we balance the total budget, then we are okay as a country, I would say. And then it becomes a question whether we should put funds from one bucket to another to help the health insurance board to get their sort of balance correct, so improve it there, worsen it somewhere else. So in a macro perspective, it's rather a question how large should the tax burden be in Estonia? And this is also a longer debate, I guess. But if we are talking about additional funds, then we should be talking about a new tax or a tax hike in an environment where taxes are already increasing. So
you don't see that coming, in short?
I don't see that coming, not only because there are other priorities like defense for now, and the budget is already in the deficit, and the taxes are already increasing, but also because of these couple of unanswered questions within the health insurance system in terms of financing, and do we understand the issue, and have we done anything within the system to improve the sustainability before we are talking about additional funds.
Sven still has questions, if you've done enough for efficiency, Rain.
We can do better, but you need to compare to the others, and then let's look at these numbers.
It's not only a question to Ryan, it's a question to the Minister of Social Affairs as well, for example, if we're talking about the hospital network, right? Mm.
And last question from the audience: can the Estonian Health Insurance Fund carrot and stick method be implemented of treatment quality criteria, not rewarding GPs and specialists for activities, but patient adherence and treatment outcome?
Yes, is the answer, and our time was up, but very quick comment, example. Screenings, cancer screenings, and many years we measured, and you know what you measure that you will get. We measured the attendance. We got 60%, 70%, 72% of attendance, and we were super happy. This year we are measuring not attendance, but how many cancers we managed to detect in the early stage, and what is going to happen afterwards. So what is the living rate after that one, and we hope that we can save more people doing and measuring that one. That is one of examples. Thank you very, very much.
Thank you very, very much, both of you. Ladies and gentlemen, this is a wrap for this panel. Thank you. Dear friends, I believe after all that discussion on health and money, we deserve a coffee break. And that is exactly what we have planned for in our agenda. I believe coffee is also served downstairs, right? Exactly, I'm getting a nod from one of the organizers. Coffee is served downstairs, where you got your snacks before our event started. And I would be very happy if you returned into this venue in about 20 minutes. Then we continue our discussions. Thank you very much. See you soon. Ladies and gentlemen, welcome back. I hope you had a refreshing break. Both coffee and oxygen might help these days to live in and work in an environment that was probably not built for this kind of use. I don't see massive ventilation systems here, and as we are in a museum, unfortunately we cannot open the windows. So I hope you managed to get your oxygen from downstairs and are ready to continue our hopefully inspiring conversation here. Now we will turn to a topic that raises an important, perhaps sometimes a sensitive question. What role should public-private partnerships play in a healthcare system that is built on solidarity? And with rising costs, growing demand and limited resources, we clearly need to ask, how can we bring the private sector in to strengthen the system, especially if we want to move towards smarter prevention, better use of data, and sustainable outcomes? And to explore this, I am pleased to welcome our three panelists for this session. Karin Varrak, Country Business Head at Estonia at Novartis. With your applause, ladies and gentlemen. Ehab Youssef, Area Head, Europe North at Roche. And Hando Sutter, the Managing Director at the Estonian Employers Confederation. Pleasure to see you all, and let's start the conversation with you, Hando. Now, we heard Estonian Health Insurance Fund. The budget actually has doubled in the past decade, but the growth of expenses have somewhat been faster than the growth that we've seen from the state budget. Now, what do you see are actually our options to get this system balanced, other than just to raise taxes, which it would, well, be the obvious thing to do, but we don't want to do that, right?
Yeah. Good afternoon. And first, before I come to answer to your question, maybe first I would like to invite economy and business to healthcare sector and join our forces here. This is a very good start already. And the second, I would take a chance to thank the organizers of the event, Swiss Embassy, and also the Swiss Health, Tech, Science and Industry on behalf of our family. Because really, maybe we don't think even every day here in Estonia that what we would do without this knowledge, those medicines, those technologies, what we are using, so that think about this for a moment. Thank you very much. Coming to your question, I think it's overall problem in Estonia nowadays. I give you a couple of figures. The last normal year in Estonia was 2019. This is pre-crisis, last pre-crisis year. After this time, we had a crisis, and crisis. We don't see the end yet. Since this time, our public spending, I mean the budget volume, has increased by 70%, 7-0. The business economy has grown during this time 45% nominal. So there is a pretty huge gap. So if we remember that economy in Estonia, we were growing very, very fast for the last 2 decades actually, then last 3 years our economy has been stalled and declined. Now it looks a little bit better, the sun is shining and everything looks brighter, but still not very stable growth yet. So this is an overall problem in Estonia. So our public spending grows pretty fast and economy has stalled. So now we are coming to our public services, and of course healthcare is one of those important public services, and we are used to have a high quality, nice public services in Estonia. So this is expectation by Estonian public and citizens. So we love it. And we don't want to talk about this, that once we love it, we can't afford it. So this is like taboo a little bit in a society. And we have raised this issue, and at least we are asking our government, so what is the solution? Because so far the solution has been that, well, we come together every year, we put expenditure in Excel, and we see that, okay, if we don't have enough, we raise taxes. If we're raising taxes, which has been now the case in Estonia for several times, then it has been contributed to our extremely high inflation. And then again, we have a higher cost, and then we again raise taxes. So it's like a cycle, and we don't know the way out yet. If we come to healthcare, and as a supervisory board member, I have seen that actually our health insurance fund volume has been doubled in the last 7 years. The volume has doubled in 7 years. So it's even faster than the growth of the overall public spending. And still we are in deficit. So this way is not sustainable. This is my very, very short conclusion. And still, we love our medical care system. And coming to this room, actually, look for the moment this beautiful castle. I was thinking maybe this was the idea to choose this room to come, because this is a little bit like our healthcare system. It's built.
We have a Baroque system, you mean?
I mean, it's a built 18th century, beginning of 18th century. Some guy who had a loved lady. It was not practical at all. I think most of the people in Estonia had no access to this building. So now we're lucky because you can enter, you pay your €5 ticket and you come and you can enjoy this, but they did it still. And we still come here, even a few hundred years later, so that we still love to be here. And it's one of the most popular buildings in Estonia, but still it's not very practical. It's very difficult or expensive to maintain for the society, but we are still here. So that maybe this is good.
Quite a painful description of the healthcare system.
No, I mean, I like the idea to arrange this event here, and I like this castle, so that thank you for invitation anyway.
Well, thank you, Ando, for an intriguing opening. Karin, now we know that the path that we are currently on is not sustainable. It will lead to a huge deficit in a few number of years. You don't even have to count a lot. 1 billion, I think, deficit will reach by 2040. That's quite soon. That's like in 15 years, right? 1 billion of deficit. So how do we move on a sustainable path? You've observed the system. Which Baroque statue would you like to remove first?
Well, definitely not. I can't give you like an easy fix or quick solution, because I think the system needs to be analyzed as a whole and to really determine which are the main pain points and which could be the best solutions. How can we save money? How can we create some cost savings? And even though we are still investing less to the healthcare compared to the other European countries, if we would even find those additional investments or pour some additional money to the system, then I think that we still would not solve many problems, that we need really substantial changes. And I think many of these changes or ideas were already discussed here on the stage. I will just bring out a couple that somehow resonate with me. I mean, this is not, I'm stealing ideas from the smarter people, but what I definitely believe are the approaches worth going for. So one pain point that we are facing is the shortage of workforce. We do have we don't have enough doctors, we don't have enough nurses, and this will only get worse. At the same time, people who are needing help, this portion of people is growing. So one of the idea is to increase the productiveness of nurses and doctors, and by increasing productiveness, not making them work more, I think that their workload is already bigger, but really looking and finding what kind of technical solutions do we have so we can optimize the workload of doctors and nurses, and we do already have some good examples.
Can you bring a few? How can you do that? Because I know doctors and nurses, they get extremely stressed when they're given another piece of software. That, oh, perhaps you will look at the patient, then you fill that database, then you fill that, and then open this program, and then that will actually make everyone's life easier. The doctors and nurses will tell you, no more software, just make my life easier somehow.
Actually,
so what do you do?
Yeah, one example was already brought by, I believe, Rain, that we have these software platforms which enable communication between the GP center and the patient, that the patient turns to the GP center, the triage is done, and whether it might be that the patient does not even need to talk to the doctor or doesn't need to go to the doctor. So this is really saving the doctor's time, and the doctor can spend the time on the tasks which are much more difficult or important. I don't know how much we are using those voice recognition technologies in the hospitals, that really the doctor doesn't have to type in all the patient data, also saves time. So these kind of solutions, I mean.
Ehab, it's great to have you in this panel. You've been listening to those conversations today. You know that Estonia, in proportion from our GDP, invests, well, roughly 7% of GDP to healthcare, right? But this is a low amount compared in Europe with our friends and colleagues who we want to resemble ourselves. Do we actually have any other alternatives than to simply raise taxes, something that, well, Ando doesn't want to do, I certainly wouldn't want to do, but perhaps we're just spending too little on healthcare? Or are we missing something that other countries have already done to increase their efficiency that we could still squeeze out more?
Yeah, thank you. First of all, thanks very much for having me. Since this afternoon, listening to our distinguished speakers and panelists, I think it's so inspiring to listen. The right mindset, great ambition in place, and it tells a lot about what could happen in the future. I believe it's a big problem everywhere, and it needs a lot of key players to make it together. It's not only one stakeholder can fix it all. And I very much echo what Karen said. If you don't fix the foundational piece out of it, the more you add money, it doesn't pay off the way you like. It will remain incremental, never go exponential, never. And I think it's all about how you are very clear about that sustainability of the system. The physical sustainability of the system, I think it's a common issue everywhere. It's a common issue everywhere. It's very alarming to know that more than 25% in the best healthcare system is just waste. It's waste. 25% minimum. One fourth or 1/3 even of the healthcare system is just waste. How can you help the system really to improve efficiency by investing in innovation?
When you speak about waste, what do you actually mean? Where does that money end up then?
It's a waste because, again, you just fix only what you can measure. And you get what you measure. If you measure something really not the right one, you just go for waste. If you measure volume, I think you just get volume. If you measure outcome, you get outcome. So this is what really triggered the waste. And my comment here about what could be done really different is start first with a mindset about how we value innovation. Innovation is actually where you can invest in order to fix those type of gaps and challenges. And when I speak about innovation here, it's both, I'm just referring to this morning presentation as well, there is an output and there is an outcome. And there is a great room here to improve both through investing in innovation. By building the right infrastructure of the system, building the interoperability between the systems, and able really to build that system that manage itself and it sustain itself. So this is from the output. From the outcome, I think we need also to start looking for understanding the more holistic impact rather than the direct cost. There is a lot of work, and Roche actually contributed in a lot of work. You asked many questions about showing case. Give us a story that tell that innovation has an impact on economy. And there is a lot of ongoing and growing evidence about connection of innovation to the value in economy.
Can you bring an example?
Yeah, let me bring few examples. And one of those examples is here in Estonia, actually. Actually, Roche worked closely with a market institute organization in Germany called Y4. It's just a market institute just diving to the data, working with governmental system to understand the cost, the direct and the indirect cost of chronic disease, and how innovation can help to support that. And really looking just for breast cancer, HER2 positive breast cancer, which is relatively small segment of breast cancer, looking for the innovation that Roche provided to the system, only within the G7 countries, like 1.3 billion euro being saved because of using the treatment early, on time, saving lives, saving productivity, and saving families. So that's just an example. Many of those examples, even here in Estonia, we did it for the MS patients. And it tells a lot about when you look only for the direct price of a product, this is not fair for the economy and not fair for the country. How you really look more holistic way about the disabilities, about the days out of work, about the quality of life. So there is a lot of work here could be done in order to show cases to the system. And that cases should help the system either to stop investing in some areas or to invest more in other areas. But you cannot fly blindly. You need really to guide yourself where you put resources when it really matters.
Hando, I know you have a peculiar hobby. You like to go to see the doctor, perhaps even more than you would need, because you seem like in a very good health. So you have closely observed how the system works. You know where money is being used efficiently and perhaps where there are still, where we waste money. So how does what Ehab just said resonate to you when thinking about the Estonian system?
Maybe I should explain first. This hobby is due to the reason that my background is a mechanical engineer and I'm now in health insurance fund supervisor. I need to learn, and I was thinking the best way to learn is to have an experiment and to participate in a system, so that I have been really spending quite a lot of time to different public and private institutions and letting a study, make a surveys, analyze. I have analyzed the bills what have been presented to Health Insurance Fund, and I make a summary soon, so that it's an interesting experiment, and I have seen really very many things which I don't see if you're not inside the system. But let's think together for one fact which is quite a typical in Estonia, but if we think about our health system spending. As a society, we spend 2.5 billion in Estonia, which is more than ever before on a health system. Has been growing very fast, 160 million in deficit, as I told, but when our healthy years were growing for many years pretty well, then since COVID time it was tall, and now we are coming down. So that I would be happy to invest more as a person if I know that this goes for a good, and the good is that we all want to live longer, we want to live healthy, but the statistics doesn't confirm it at the moment. So that for me, as engineer, this sounds suspicious. So, and then I wanted to understand why, what is going on, and a few observations. One is that what I see in, if you go cardiology, let's say in Tallinn, our main hospital, or Tartu or something, it's amazing what kind of technology I see there. I can't evaluate, is it the latest model or not, you can tell me later on, but at least it looks something very expensive, looks something very professional, and that what they can do there is amazing. So everything what happens inside this department is amazing. Mm-hmm. So service, equipment, results, what they tell you is amazing. But if you go out of this room to another department, they start from the scratch. So you again, like on your own, on between, and even in the corridors, you need to find a way. So what I want to say that the system, I have been building up quite a big organizations in my life, and you know, always if you see a silos building up in organization, this is is taking down efficiency of the system. And I have seen a lot of silos inside the Estonian healthcare system, and it's not only a private versus public, but it's even inside the private, inside the public system, you see silos, although they are very nice silos all. So this is one observation. Another thing is that I can feel it as a patient that they really want this analysis or this treatment made in their department.
They get money for it, of
because
course.
Because if you go out of the department, they are not getting payment. So they're interested to see you more often. I'm not interested to see them so often because I want to go back to my work and earn money. But they want to see me more often because they can issue a bill. And I have been actually archived to all the bills they have presented for me. I can understand them very well because those bills are not small, you know. Of course, I have paid all the taxes and quite a bit during my career, but still they present the bills so that they are motivated to see me more often. I don't think this is wrong. They should also be motivated to see me as little as possible and maybe to use data instead, as you say. So, and the third thing is that, again, as a common sense, so if we have any technology in the world which will save at least one life, then we should use it. So it's a no-brainer, so that how we can even discuss it here, if we have technology, you are here, you want to offer to Estonians your latest inventions for us to live longer. Why should we discuss it? We should welcome anybody who want to bring the technologies here to test it in our system. We have made a Tiger Leap. Have you heard about Tiger Leap? No. It's around 20 years ago, we started to digitalize our public services in Estonia, and we did it pretty well. Why should we make our data available for any medical innovation in Estonia and be like a showcase? Because we are, you know, we feel big, but by statistics, we are a pretty small country, so that we can do it.
So let's take those elements that Hando was describing, let's look at them in more detail. First of all, this volume-based service, right? The more services that you offer to the patient, the more money you get versus, well, value-based healthcare, or one of the ways to describe it. Karin, what kind of attention do you see actually when looking at the healthcare system in Estonia in actually crossing from this volume-based approach to value-based? Who's against it? And well, I can only guess who's against it, those who get the money. But how do you overcome this? And is this a genuine issue that we actually closely need to address?
It certainly is a genuine issue, and I'm really glad that Hando brought it out, that somebody from like outside the system. And I don't think it's, or I disagree that people who get the money are against the value-based healthcare or outcome-based healthcare, but they are not the ones who should be implementing that. So, and it was already a lot of talk about that we should be, that we can, this kind of approach is not sustainable anymore, that we need to shift from the fee for service payment models to the outcome-based or value-based healthcare. So I know it's a very, very complex issue, and I think we've been talking for years about it. So, but now we need those bold people, smart people, really start making the changes.
We need Ryan with that stick in his office, operational.
I don't think that stick is, at least from the beginning, a good idea, because the point of the system is not punishing those who are not providing maybe the best outcomes, but really rewarding those who are able to produce those good outcomes, who are, you know, really the health insurance fund should prefer those providers who can offer earlier detection, better prevention, better outcomes. So I think it's already on the very high on the agenda, moving from fee for service to the outcome-based service or models. So now we just need like a little pushback.
Ehab, in your experience, transferring the system from one financing model to another, how painful is that?
It is painful. For me, there is a clearly burning platform now. There is a move has to happen, otherwise the system cannot sustain its performance. Let me be more blunt here. It needs leadership, it needs bold decisions, and then it needs typical change management. And it needs education and learning as well. You need to educate and upgrade the capabilities of the leaders who are taking the decisions, how to improve digital capabilities, and how to lead and navigate through this new complexity and new ambiguity. It needs investment because sometimes you avoid because you don't know enough how to do it. Sometimes, at least my own experience working with people, sometimes you avoid because maybe you would like to do it, but you cannot do exactly how to do it. So equip people with training, with development, with the way they can do it, and just allow people to do it. And I think I feel very inspired listening to the leaders this morning, and now about all panelists who are ready to take the decisions, and they see clearly the need to do that. I think this is exactly the time to do it. Yeah.
Ando, what role do you think should or could the private sector play in this new order of healthcare financing? Do we need a change in this as well? Do we need, or how will the system be more effective if we open the market, so to say, to more providers? Do you see a need for that?
First, Estonian business is having a twofold interest there. One is, as I said, we can't afford it, and we are clearly on the position that the more tax raises in our stagflation system is not doable, at least in a shorter run. But the second is, which is also existential, by the way, is that we just don't have people. We need people to stay active longer time. Demographic situation is even worse than in most of European countries. It's a problem everywhere across Europe. The people are the fast-growing deficit. Yeah. And if I just say that in Estonia now our economy has been declining for a third consecutive year, our unemployment is, we have not seen any rising unemployment. Still, in most sectors you have deficit of people. And now if we expect economy to start growing again, the lack of people will be number one problem, very fast, bigger problem than capital or anything else. So our existential problem is that we want people to stay healthy on the market, contributing to business society longer, and this is existential need here to build up our country and the businesses. So therefore, we want to be part of this, and we want to support this change management, as you say, in many ways as we can. And one good example is that now the Prime Minister has invited the Economic Efficiency Advisory Group, where I'm also part of, and we are gathering every second week, and we are preparing to the government hearings the packages, how to cut the bureaucracy and make our country and public services more efficient. And this is very, very good cooperation. We had the first 32 proposals voted by the government last week, and it goes ahead pretty well. So why don't we do something similar in healthcare? So let's find out first of all, we need to analyze and put it into the numbers. And I think the effect and priorities are quite easy to find, not only on the healthcare spending-wise, but also maybe value-wise, what we can create when people are healthier and staying more on the labor market. Let's put it also into some numbers. And then let's describe this burning platform, as you say, and then if we all agree that something needs to be done, I think that we have very experienced change managers who can really come and support this change to be made.
Karin, we have a solidarity-based system in Estonia, and we're very proud of that. It works well. We have generally good access to the healthcare system for anyone in the need, well, except for long queues in certain disciplines. But what kind of a role do you see the private sector could actually play in this solidarity-based system?
You mean the private healthcare
Yeah, the private healthcare, exactly. The private healthcare providers. What is the role that they could play that would not derail the solidarity-based system, but actually make it more effective and still provide access to everyone with favorable and better outcomes?
I mean, I think that these two systems, the public and the private, should and could be complementing each other. Although it's difficult to give a good answer to your question, because I very much acknowledge the risks. Like we said again, we are competing for the same, they are competing for the same resources for the same people. So how do you make sure that the public sector does not suffer, and how do you ensure that the inequalities do not increase while you are engaging the private sector more, which of course is very saddening to read articles about those two sectors somehow competing or polarizing. Then I think that what can be, or what should the approach be, that the health insurance fund really should analyze what kind of services can the public sector offer. Is there a need for a specific services, or is there some kind of gap? And maybe here the private sector should step in. So we need to find a way how to make these two systems work together, because it's not, it's not easy, and there are threats. And as I understand that, read some researches, then in those countries where they have increased the involvement of the private sector, the quality of healthcare has not actually increased.
Yeah, well, you've worked with many health systems. You know what's happening in Europe and in the world. What are the most important ingredients for a successful private-public partnership?
Plus one to Karin are around, it's a very delicate how you make that balance work. I believe competition helps. When there is a competition between systems, it makes sense. It drives everyone to seek perfection, to compete. As long as there is someone is overlooking that well and ensuring that the two systems are complementing each other, closing gaps from each. If there is a gap within the public system, the private could close it on a bridging base till the public system is catching up, ideally to keep the patient within the umbrella of public, but you still can use the system, but you need someone really overlooking the system and make the right balance happen.
Well, in Estonia, public and private hospitals or companies often compete for the same personnel, right? You have the same nurses, the same doctors, in principle, offering those services to the public. So is that a balance, a delicate balance that we need to keep in mind?
Absolutely.
Handa.
I think it's a little bit misleading because our competition is across the Gulf, and we have seen it happening for a decade or even more. So I think the Finnish language courses are mandatory in Tartu University, or at least very popular, if not mandatory.
Doctors go to Finland.
Yeah, but why not? Because it's a short trip, very nice boats, and and salaries are 1.5 times higher. So to speak that there is a competition and we should avoid talking about private sector involvements in the system due to the fact that they take away the people is just not correct. We have a competition anyway, a cross-border competence, and we should see it as it is, so that let's see the facts if somebody is thinking it's not true. But another thing, I think we should not put it up in a way that the public-private, we should maybe see the good practices, what we have already today. Think about yourself, you are a private company, right? Listed.
Yeah.
So with how many public companies across the world you are cooperating? in a good cooperation.
You mean public?
How many partners or companies or customers you have in a public sector?
Multiple, yeah.
You see, it's a great cooperation. They can manage. Why we can't do it inside Estonia? So I mean, it's not even, is it public or private hospital, but maybe we can develop some good high-tech public or private driven technologies in a public hospital. It's also cooperation. So who owns the property is not even the case, so that we should even stop opposing those two systems, and we should make them complement each other. Exactly.
Yeah, I think the collaborative mindset is critical here. Is you are not competing rather than collaborating, and that applies as well between private and public, between pharma industry and a lot of other corporates which can complement a lot of gaps within the system, and how you find that common ground that makes sense for both to cooperate for the benefit of the patient.
Karin, you want to add something to that?
No.
It's all clear.
It's all
Right.
clear, yeah.
Hando, I know you've also thought about the occupational health checkups as a potential to actually guarantee a healthier working life for people. So what is the current state of play here? I know, well, everyone gets the invitation to visit the occupational health doctor. What happens to that data? Is it actually usable across our healthcare system, or is it somehow missed opportunity?
Yeah, let's put it into context again first. We have 1.4 million people in Estonia, roughly. Half of those people are in the labor market. Others are kids and the pensioners. So we take good care of our kids. Thanks. We take good care of our pensioners and older people also very good. But this 750,000 people in working age they manage by themselves more or less. So. The only rare case when they meet the medical system is if their companies are sending them to health check, which is mandatory for the employers like we are, to go and check how they are. Now, we have a joke that, every man in Estonia, they have a car, they go to the technical checkup twice per year, so that they follow exactly when they have to go and they know exactly how the car is doing. But they go to check their own health only when the engine is totally broken. So now, okay, we have to send our employees to the check, and this is cost of employers. We have to pay for this, but then, and it's useful. Many our staff are saying that, yes, we got something now, we understood that we need to move more, we need to eat healthier. We are working with a computer long days, maybe we need glasses or something, so it's useful. We didn't know this. We got some useful information about our health. And then next, what happened next? So it comes with a recommendation, you should contact your doctor. There is no automatic link. And this is totally waste of time, because women, they go. Men normally, they don't go. But even if they go, then somebody may show up here, then we take another group of doctors who need to and validate this information, and they send it to a third doctor. Why should we do this? Why we don't use the databases, maybe automatic links to connect it and send directly? So the primary level of our health check, and especially of these 700,000+ people in working age, is actually our concern. And if I put one more fact, which I have learned from our insurance fund, is that 60% of our health system spending goes to 5% of population. And now, what is the common nomination of this 5% of people? Any guess?
They eat a lot and like their beer.
More or less like this, yes. It's a lifestyle issues. Lifestyle issues, 5%, 60% money goes to 5% population. And I think if somebody would remind us every year, don't do it. Be honest, don't do it. Let's spare move more, and healthy foods. So I think maybe our burden to a healthcare system would be less, so that seriously, I think during those years when we're active, and if we are paying more attention to our health, maybe it would be better.
Somehow the red timer has reached 0, but it would be very unfortunate to leave this panel without any questions from the audience, so I'm going to take at least one. Name a good example of public-private partnership in healthcare and key obstacles that need to be removed for future PPP's success. Karin, perhaps we can start with you.
Well, I would like to point out the patient pathway projects. One is definitely where Roche has also been participating, the lung cancer patient pathway. Just a year ago, Health Insurance Fund started the Pathway Accelerator. We're also public institutions and private sector was participating, because this is like a good link to this. How can we, again, coming back to the beginning, move from this fee for service to the outcome-based approach? Because then we need to understand what do we measure, how do we evaluate the quality, how should we pay for the outcome. So I think those are quite successful and definitely necessary collaboration projects.
Any factors that prevent this cooperation from happening?
One thing is definitely the access to the data. I mean, even if we say within the government that access to data is difficult, access to data from the private sector is even more complex and difficult. So we really need to enable the access to the data for the private companies as well. And we do have some mechanisms there that we could do and implement. So.
Excellent. Ehab, your thoughts?
Yeah, I'll build on the same example, which is lung cancer. And because lung cancer became the treatment and the innovation for the treatment became really amazing compared to the history. You had earlier 3 types of patient, now you have multiple genotype patient, and you have a treatment very much can really help. That's why there is a very good partnership being developed locally here in Estonia, which is the lung flag software. It's an artificial intelligence-based software algorithm that can help to bring data to it, and that help you to spot those segment of population that have higher probability to get lung cancer. That cooperation actually, and this is part of a very successful partnership, the scalability that you can really leverage that across multiple countries. And actually this one was, the data was presented in ESMO in Barcelona last year. And it's been also localized and identified from a quality, securing CE approval soon. And that will, as Roche, we plan to expand that and scale it across many other European and global countries. And it was developed here in Estonia. So this is an example of cooperation, scalable for the future and for others. I think the key factor for success here was all stakeholders were involved, were committed, were interested, and very clear on the outcome that they would like to achieve.
Hando, as a last takeaway from this panel, what is perhaps the most important step or 2 steps we need to make in Estonia to actually make public-private partnerships in healthcare not simply possible, but an efficient way forward?
First, I think those both examples are super good examples, and we should do it much more and much faster. By the way, who has been given access to their own, to your own data for Google? Anybody using Google services?
Yes.
Don't be shy. I think all of you. Be honest. Yeah. Mm-hmm. I think all of you. So did you know that this is American clouds? We are sharing with American cloud all our private data. Why? course, they're giving us interesting services. You're benefiting out of these services. And you clicking, yes, you agree with everything they ask.
Blindly.
And now there is coming a company saying that, hey guys, if you give us access to your data, I can give you more years to live. And we are hesitant. Do you want to click or not? And I'm not sure I had even a chance to click it, but I would like to click it. And yes, I'm agree. I'm ready to give my data for those guys to give me more years. So, and this is, if you ask Johannes what it should be, I think that we should explain to the society why our data, how our data, if we give it to technology companies, can earn us benefit. Of course, we need to be cautious and not to go to the private areas, and we need to exactly define the borders where which will not cross, but this is something what we have to do, and it's not by degree, but we need to explain it. We need to explain it to the people, and Estonian people are digital related people, so that they will understand it, because we just love our digital services, what we have. But here, nobody yet didn't give us a chance to click this box, so that we should give this opportunity for our people, and I think they will agree.
Karin, Eha, Hando, thank you so much for this discussion.
Thank you.
An applause, ladies and gentlemen. If we only had 90 minutes for this debate, many other questions, important questions, could have been addressed, but what can I tell you? It's such a wonderful weather outside. We can't keep you here until the sun sets. So let's move on with the agenda. Now, as we've heard, a discussion about the possibilities that public-private partnership could actually bring to healthcare, how not only Hando, but I guess I would also like to click, okay, accept more healthy years in my life. Yes, I'm happy to do that. Not just Google terms, but also more lives for more years for me. It's a good time to ask what are actually the government's plans in this digital domain. So to share her vision and priorities from the Ministry of Social Affairs, please welcome Jaanika Merilo, Head of Digital Health and Care. The floor is yours.
Yes, hello everyone. So many familiar faces. It's a good sign, right? Well, I will a little bit refocus my today's presentation because so many familiar faces and you've heard it before. But actually it was very interesting to hear these questions which basically say it's private or public, that there is a rift between private and public. I come from the digital domain, which means we can do nothing without private. It's basically private first, which means in Ministry of Social Security, in Social Affairs, we don't code anything. All of our solutions are made by private sector, which means we have a little bit different problem. How can the private sector develop faster so that we can implement more solutions? And our today's challenge is a little bit even different, not that we're opposing the private sector, but how can we make data available faster? How can we ease the burden of legislation so that the startups can be born faster? How we can deregulate the overly regulated innovation sphere in regards to AI acts and medical device regulations and whatsoever. So we find ourselves actually very much in the same side, meaning that how can we do faster? Because if the private sector doesn't develop solutions, we don't have them. We cannot implement them because it's up to the private sector. But yes, starting from the heritage, actually, we have had 25 years of developing our IT solutions. And 25 years, it's quite a long time, actually, which means that we found ourselves not to be pioneers anymore. Yes, pioneers, but not by a new technology, but by constantly having the need to renew our technology, to invest in getting rid of these 20 years old systems and to renew ourselves. And I think we're in the very interesting stage of facing the new challenges, meaning that we can have the newest technology, and to make and accelerate the growth so much faster. When I heard about this cooperating with the private sector, why don't we welcome everyone. We just this morning welcomed. Meaning that, yes, of course, we should implement every innovation that saves money, but then again, it's also our priorities. Meaning that still you have limited resources. It sounds so good that we should do everything. We cannot do everything because there is still limit in time resource, in regards to humans, professionals, companies, so we need to prioritize somehow. So during our last year, we tried to prioritize together with the healthcare professionals, together with the private market, on having these limited resources, where should we pay our attention so that it would be most efficient use of resources and the biggest benefit that we can get. The slides are lagging behind, they're not so IT-driven as we are here probably. But yes, so during the last year, we actually gathered 20 stakeholders, even more, from the private sector, 3 associations from private sector, the biggest universities, the doctors' associations, several of them, and asked that what problems can we solve for you so that you will feel empowered and, yes, I know, but it's lags, still lagging. Yes, and what we can solve and prioritize so that we would implement innovation faster, but it's not so much about innovation, meaning that innovation is always a tool to increase the lifespan, and we defined our priorities. As I said, I'm skipping because I see so many familiar faces, getting down to the point now. And we defined that basically we need to have this basis in regards to having the fundamentals of being very agile, being fast, being able to implement the change fast, as well as extremely important is cybersecurity as well. But we need to, as I said, actually to make our legislation more flexible and agile. It sounds so strange. Estonia is so famous for being this very quick and sharp and witty country and implementing the change. But now we notice that we have actually come down to being part of the European Union that is not always so fast. It sounds strange. So our today's challenge is how to deregulate ourselves. How to create the sandboxes when we can still be agile while not breaking any laws, while not breaching any private security, and so on and so on. So as I said, we don't have this challenge, private versus public. We have the challenge how to do it together. So in our strategy, we defined that basically main thing is data and having high quality, standardized health data, because it enables everything. It enables the healthcare professionals to have better data for decision-making, for improving the healthcare quality. The policymakers need health data to have fact-based decision-making, basically. Of course, the private sector needs data to make new solutions. The researchers need data. So we defined in our strategy that basically the cornerstone to everything is to be agile, to have the new services out and fast, based on this high-quality data. And this is an issue always, meaning I haven't seen any country who says that we have 30 years of high-quality data and it's all there. It's always a challenge, it's always an investment. And we're now working on improving an access to data, which means that, yes, definitely we can see that the private sector cannot get the high-quality data as fast as needed. Again, that means the regulation. And I think actually we're thinking about quite cool approach, if I might say, meaning that we don't want to deregulate just access to health data, because very often the researchers don't need just health data. They need data about education, about from population registry maybe, about social conditions maybe. So they need lots of data sets. And even if we make health data faster accessible, it doesn't solve really the problem. The same researcher would be still waiting and applying for the population registry data or applying for the social data. And still it means that you're waiting for a year with your innovation, your investors are getting nervous because you haven't even received the data. But then the fun part starts. Then the clinical trials, then the certificates, medical device regulations, AI acts, and we're quite fast from needing a data just to pilot something up to 3, 5, 7 years of getting the product market ready. And actually, this is our challenge. Meaning, as a government, we very much welcome the digital solutions. We have in Friday the pitching day between Estonia, Finland and Latvia. We're pitching the digital solutions, which are very cool, AI, ML. Someone from here, the audience, is also pitching there, not saying who. But again, these are just few companies that have made it. We were almost joking that in Estonia, what do you think how many companies we have that are meeting AI regulations as well as have MDRs and is meeting AI Act requirements and so on? You can just say any number. No, not you, Lisa-Lotte, you know. Anyone who knows, no. Just guess, basically, how many innovations we can go to the hospital and say, hooray, you have the certified product ready and roll out. 1.5. Not kidding. Which means that we have the first company who is corresponding to all the MDRs, AI Acts, and everything needed. So I'm trying to say that we have different challenges. We have the challenge how to support private sector in getting there faster. Because if they don't launch solutions, we don't have solutions. So this is a quite, let's say, I hope innovative concept in regards how to make data faster available. Maybe some of you have tried Kapsuli, Finnish FinData, which means that you will have an access to health data faster than in most of the countries because the processes are streamlined. They don't solve really the whole problem. And they are kind of dreaming about the same system that we're working on, which means one access point, one application point, when you can apply for any data you need. You need to run, for example, cancer research. Maybe you need the data about social conditions. Maybe you need the regional specifications. Maybe you need the climate hazard information and so on. How to apply from one place, how to streamline getting data from any ministry fast, how to not go through all the verifications and data permits in parallel and hassle a lot, but how to get the data in one location and secure processing environment in, let's say, half a year, instead of 1.5 years and multiple parallel processes. And that needs really very much cooperation. It sounds like it's so easy, just launch the application management. Yes, but all the ministries have to kind of cooperate, meaning to make their data available, to improve the data quality, to label the data quality, to have the data catalogs, and so on and so on. So from let's launch any innovation that there is, yes, let's launch any innovation that there is, but in order to have this innovation, we need so much to support the ecosystem. And one of our, I think, cornerstones in e-health strategy is implementing the private market into our e-health strategy. When we launched it a few months ago, we didn't only write the strategy together with the private market, but actually we even integrated it down to bullet points, that government is not doing that, private sector, please step in. The health monitoring, remote health, telehealth, whatever solutions, it's really important. We will not be doing, but we will support you all throughout the way. Of course, patient treatment pathways, yes, but we can do it as fast as we can, basically. Again, there is still limited resources, and you have seen how many people were missing from the healthcare sector that have time really to work on innovation. We have the same lack of resources actually in regards to collaborating with private sector and so on. So it's not about only speed, but about creating this ecosystem. And again, very happy to support launching any innovation that you have. It shouldn't be like you're knocking in the government's door because we have the same goal. We need your innovation so that we can meet our health targets. And people cannot live longer if we don't have digital solutions that would be supporting the healthcare professionals, that would be supporting the patients. So if you have something, please knock on our door. And because, again, it's not about you should do something, we should do something. And if you have the solution, please offer us. If you have any kind of, there was a topic about deregulation. We're going around and around and asking, what is burdening you? What can we cancel? So any wish list would be great, not to have this theory, let's do something. Wish list, solution list, we're very happy to work with that. Very unfortunately, I have actually airplane to catch in I won't be saying soon. In an hour and a half, I will not be speeding. But this is why, sorry to keep it a little bit shorter as planned. I can see the clock is still ticking, but we'll be very happy to answer questions if possible.
Thank you very much.
Not what you expected, no?
You actually helped me to get back to the schedule after having a bit of a longer panel.
You're welcome.
So really appreciate that. So we do have a question from the audience. What kind of support mechanisms are available for healthcare PPPs?
Different, meaning that we have a health insurance fund, which is supporting patient pathways, which is supporting innovation, different innovative solutions, because it's not only a startup having solution, but it's often that you should also provide the access to the healthcare system, so that you would walk hand in hand and actually tackle all the issues, let's say. So the healthcare fund has mechanisms, and also we believe very much in different health founders. Katrina was here, as well as the AES support mechanisms. AES has very good also this, development supports, but it's quite often that as soon as the product is ready, and hello to Siim, the product is ready, we're using the product, and can I say we're very happy with that? I probably can. So as soon as there is something ready, we can start working with it to help to pilot it, or help supporting whatever is needed, because the problems are very different. Someone has a kind of issue with having the clinical trials, so we can probably help to find the healthcare provider who is ready to participate in a clinical trial. Someone has a problem with meeting MDR, medical device regulations, because the financial burden is too high. There are definitely different support mechanisms in AES, in MetroCert, and so on that are tackling this problem. Then we're cooperating with Accelerate Estonia that says that as soon as you have something interesting to pilot, let's address the legislative burden and see what we can not cancel, but where we can make compromises in order to launch it, like the pharmacies pilot that are doing. So it very much depends on what is the challenge for this startup or this innovation provider, and then we can help solve it when we understand what it is specifically.
I understand you still have a bit time before
Yes,
you need to
yes.
head to the airport. So a few more questions. When will the one-stop shop to derive social, educational, and other data become available for private sector?
We're working on it now with Ministry of Justice, Ministry of Economics, Ministry of Education, and so on. We hope it will be 1.5 years approximately if we will get the support of the cabinet, which means all the ministries will say, yes, this is the way to go. We're hoping it is the way to go. We certainly, unfortunately, need some investments. I hope the private market will participate here in making the secure processing environments. Don't want to do that as a government. Private market has the role to play. But first we need to have this concept approved, and I think we will be in cabinet by autumn by having this one-stop shop concept in place and confirmed by all the ministries. But it's going quite surprisingly good. Again, knocking on wood.
I hope it will continue that way. How can we deregulate provision of healthcare technologies?
Yes, again, what exactly? Meaning that what are the challenges? We cannot deregulate the European directives, and they're quite burdensome, to be quite honest. We cannot deregulate as such medical device regulation or AI Act. We can deregulate, probably we're looking for the most efficient ways in regards to let's create a sandbox and let's make certain piloting environments where you don't really deregulate, but you create an opportunity to pilot some new technology. Right now, it's quite new thing in regards to AI Act to create this sandbox, and we're trying together with Ministry of Economics and Justice, that are basically the drivers of deregulation, to find that what are these loopholes is a bad word, but what are these nuances that we can ease for the trial period. So, but we're deregulating basically, it sounds very strange, but we're deregulating on a monthly basis, which means that right now we're working on rewriting the documentation requirements that have been waiting for deregulation for some time.
Jaanika, thank you so much for your presentation.
Thank you.
I hope you catch your flight, and I hope
hope you
Estonian digital healthcare is, well, moving to the right direction. Certainly seems that way from your presentation.
Thank you. And sorry so much to have to run.
Thank you. Ladies and gentlemen, now that we've heard from the ministry, it's good again to invite good people onto the stage to discuss how it again looks in practical life. We have an audit manager, Rauno Vinni, and a founding partner at Health Founders, Erkki Mölder, joining us. And Rauno also gets a microphone, then we're ready to go. Oh, we have a handheld. Right. So, Erkki, do we actually know where Estonian healthcare money goes to? And how do we understand this today?
Yeah, thank you very much, and thank you for the organizers to inviting me here to share the experience and my ideas on the topic. So I knew that you are going to ask that, so I'm going to ask the technical team to put a couple of slides on the screen. I'm going to guide you through the way how I see it. It's a busy slide. Some of you have seen it. Basically, the money goes into 3 different areas in the healthcare. The green one is related to injuries. The orange one is related to infectious diseases, and the blue one is related to lifestyle diseases or non-communicable diseases. And the way how you should read this is that the size of the rectangle shows how much the money goes there, and the intensity of the cover shows the growth. And what you see here is the snapshot of 1990, where the money goes. And this is the global way. And now, 35 years forward, let's see how this looks in 2021. Okay? So what you see is kind of the huge trend towards the blue. And this is due to the technology. This is due to the technology that keeps us alive. This is due to the technology that doesn't allow us to die, not healthy, but aging population. And you see that everything related to blue is kind of growing fast. And if we go now to the Estonian situation, then it is a little bit similar, not completely. Of course, first of all, the statistics of Estonia in 1990, maybe not something that you should look into and trust too much. But believe me, if you even kind of move 3 years or 5 years further, it looks very much the same. And if you look now at 2021 in Estonia, you see how much the costs of non-communicable diseases is growing compared to the other ways. So I think we know where the money goes, but I think that we don't really appreciate that the health in this blue area is not generated in the hospitals, if I may use this term. This health is not generated by the doctors. This health is generated by ourselves, by hundreds of small, tiny decisions we make every day.
And that we will again be able to make when we leave this conference and go for the snacks.
Yeah, or walk home, or take 2 glasses of wine or 3 glasses of wine.
I plan to get some snacks and perhaps walk home after a lot of convincing from this stage.
Yeah. And by the way, whatever country you look, kind of the trend looks the same. Even Africa, even Asia, even whatever country you take, kind of the trend is the similar.
Or perhaps I won't have snacks, now that you mention it. Now, Rauno, you're in the State Audit Office. How much of this data is actually dictating our policy in the state, where we put our money, how we design our healthcare policy? Is this a screenshot that all the policymakers constantly look at and try to understand how to diminish that blue part, or at least like make it smaller?
I think in broad terms, do you hear me? Okay. I think that in broad terms, the policymakers do know that the picture is as it shows. But one thing is knowing and the other thing is doing. I guess that one character of Estonian policymaking in healthcare is that we have quite adequate big goals, like accelerating the rate of healthy years and so on. But the problem is that micro-level activities are not well connected to this big vision of where society should go in health. And we have meso-level goals. We have lots of things going on micro-level. We have treatment guidelines and so on. But we have a lot of questions about how the policy is made on meso-level, meaning that how ministry and also health board and health insurance fund and so on are implementing the policies that are well crafted into the nice development plans. So there is a disconnection, I think, and this is something that could be better in Estonia.
Erki, could we also measure or model the economic impact if, let's say, people live longer, healthier, and stay productive for more years? Do you have a visualization of that somewhere as well?
In my mind.
In your mind, okay. How do we get that from your mind to the policymaker's mind, is then the question.
This is interesting because I come from the world of technology, and when you look at adopting any technology in the healthcare, there is a technological element, but there is a clinical proof element, and then there is a health technology assessment element. So there are frameworks, actually, if you want to bring something new to the market, that you have to jump through the loops, and proving the efficiency of a solution is actually one part of that. Now, the problem for Estonia is that it's a country, but it's not a market. So me as the investor, I'm pushing the companies out from here because, yes, you can prove that something works in Estonia, but if you want to get my money as the venture capitalist, you have to scale. You cannot do it here. So the challenge for Estonia is to be as similar as possible for the big markets. Because otherwise, guys like me are pushing the companies out from here too early. Certainly, there is a kind of element of Estonian me in here that I still want that the companies, test in Estonia, and hopefully, kind of these technologies can benefit the health in Estonia as well, or Estonian people. But what I wanted to say is that the market trends are not favorable for us. So us as the small country, we have to make extra leap to keep the technologies here and to be kind of in the frontier of using these technologies. Unfortunately, we don't see it today.
I've heard quite a few painful diagnoses today on this stage, but Estonia, it is a country, but it isn't a market, must be one of the more painful ones.
And this is not by me. I'm quoting our ambassador to UK, Mr. Viljar Lubi.
Well, anyway, it's the pain is growing, Rauno, but you wanted to comment. Yeah. Probably not that phrase, but something else.
I had a small comment. We did an interview with our colleagues a few months ago with a data scientist in health policy field. And he said that I have in my head all the models that a policymaker could use in order to make better investments in health policy. Meaning that if you give me 1 million euros, I would be able to say in which programs or in which measures or interventions the state should or could invest. So I think that we have the capabilities of crafting or designing the models we need to make good decisions. But the thing is that every other policy field is capable of doing the same. And there is still competing on the resources of the state. Well, the same could be said in education. The same is in every policy field that policymakers could come together, analysts are able to say that if you put €1 into education, we get 10 euros back in 10 years or 15 years or 20 years. And the trouble is that you have to make the investments now, and there is a lack of resources. And on the other hand, then you have to be really good at prioritizing. And then this is where the models come into play once again, that you should have as a state the models ready. You should have very good data to make quality decisions. And that means that you have to be ready when the opportunity comes to make the investments, to make the good decisions you need in health policy.
Erki, so we're really proud of Estonia's digital achievements. How much of that digital potential is actually being used in practice? Where are we doing well? Where are we actually still far behind others?
You mean in healthcare?
In
or
healthcare,
everywhere?
yeah.
I think in healthcare, we are pretty good at gathering transactional data that helps us as the taxpayers to analyze whether the hospitals try to trick the payer or not. And actually, I think that everything that you see on the timeline, how our IT systems were developed over the last 20 years or 30 years, it is a little bit kind of resemblance how this interaction or relationship between the doctors and the insurer actually happened. So we are very good at measuring what's happening with the patient when the patient enters the hospital door and when he or she exits the door. But we are very bad at gathering the data and analyzing the data. What happens before that? What would be the potential kind of benefit of getting them sooner there? Or what would be kind of the downstream cost savings if this person would get to the treatment earlier? We are not really measuring that, and kind of this is why we see that bang for the buck in Estonia is really good. But if you look at lifespan, if you look at health span, then we are average at best.
So what do we need actually to shrink that huge blue part in that screenshot that we
it's
saw
super
before?
easy.
Well, give us that easy solution then. Go ahead.
You just have to incentivize the doctors and the clinics to embrace innovation. And they are not. Because several things it has been said. It has been said several times that they are optimizing for maximizing the agreement with the health insurance fund. This is the current system. What do we buy from them? They are maximizing it, and I don't blame them. Kind of, we are all maximizing what we are being paid for, and kind of even it's worse because if they would innovate today, the health insurance fund in 3 years would audit the books and says, "Hey, you are making profit here. I'm going to decrease the payment for that." I'm a little bit exaggerating, but you get my point, right? So why should any sensible head of hospital do anything there if they know that it is temporary? And this money will be taken away from them in 3 years.
They don't have the stick, but they don't also have the carrot.
Mm-hmm.
So your proposal to get moving?
My proposal is to put the incentives into the right place, agree who should be really driving the innovation, and incentivize properly. And moving towards the value-based care by measuring the right results is the very good step to the right direction. Having said that, I think that no country in the world has figured out how to do it properly.
That's an easy task, it seems, to get it right first time in Estonia.
We're a small country, and this is what we are good at, Estonia.
So Rauno, how do you see this situation where the system kind of, continues in the same path because the motivation is in place, but we know that the end result is that we're missing €1 billion soon?
I'm not going to repeat what has been said already, but I will enlighten from my perspective, or the perspective of National Audit Office. What we have seen in our audit is that we should invest more in prevention and prediction. And as we say sometimes, which is also in some discussions previously was already mentioned that we should concentrate on providing the right service to right persons on the right time, so that, as we know, enormous sums of money are going into curative services and not so much into prevention and prediction. But the question is how to turn the tables around, and that's a tricky one, once again. I also studied political science, and that's why I am kind of a realist in that sense. The problem here is that it's very hard to sell to politicians that prevention is investments. For the reason is investment, because every moment in time the politician has different proposals from different civil servants and ministries on the table, so that you have to be really good in making your point and in your narratives, as Sven Kirsipuu was telling you about earlier.
Erkki, now you said that no one has done it right, but people and countries have tried, right? So who can we actually learn from?
Oh, this is a tricky question. I think that elements can be learned from very different countries. Certainly, if we want to see what can happen if do things right, is Japan, kind of very old population, very expensive healthcare, but very inclusive. Clearly, kind of this is one way to look at how the extremes of the social trends will shape the industry. To some extent, what we see from the digital world is UK and Germany and recently France, how they have developed very structural reforms and changes, how the digital solutions can be adopted by the doctors.
The Germans are doing better in their digital healthcare domain than Estonians, and also the French.
It's painful, I know.
It's getting more painful.
It is.
As we go forward, so maybe I'll need a glass of wine after all this.
French too. So the reason I'm saying that is that if you look where the money goes in the healthcare, then 50 to 60% goes to the personnel. And this personnel cost is not wasted. And this is used primarily when the doctor or nurse has the FaceTime with patient.
And with FaceTime, you don't mean iPhone FaceTime, but good old analog world FaceTime.
Real FaceTime. So the real trick is to how, on average, can you decrease the FaceTime? Because this is the only way how, from the perspective of unit economics, you can make things cheaper. Because 50-60% of the costs are related to payroll. And the only thing that you can do it is that you have to persuade three parties, patient, doctor, and the payer, to shift to more online, more technology-driven solutions, so that the easy cases are kind of being pushed to the nurses, being pushed to the technology, being pushed to the AI. I think the technology is there. The technology is not the barrier. We are missing social agreements and social arrangements, how to really promote that. Because from the doctor's perspective, and this was quoted here before, if you would have 5 minutes, what would you do? I would see more patients, right? This is kind of the thinking currently.
Rauno, is our only way out to have less FaceTime with our doctor and perhaps more FaceTime on our iPhone screen with AI or a virtual assistant that, well, hopefully says the right things?
I hope that technology helps. The question is how much. I've read different articles on the question, and some sources say that in healthcare we should maybe get 5 to 10% of productivity raise with the help of AI solutions. This was a study made by Americans in US 2 years ago. And then again, IMF released just a new report on how much AI could support productivity in the state. and in the European Union it was only 1%, 1.1 to be more exact. It's heavily dependent on the area of life and also the preconditions, but the thing is that if you want to gain 5 to 10%, which is quite a considerable sum already, of productivity raise, you should invest at least in the start into this technology, then into training, then into data management, data quality, then also into training. And one of my messages today here is that we should also invest into the capacity of state institutions to do all that. I mean that I think from National Audit Office's view, the problem in Estonia is that things take too long to implement. In some reports we have said that we don't need more analysis, we need decisions, we need implementation, and for that we need really capable civil servants, we need civil service which is fit for purpose. I think that the number of civil servants is of secondary importance. What is more important that they are capable of doing what is needed, that they are capable of supporting innovations and making all these nice things that Jaanika was talking about. But in reality, what we see and what signals we get in National Audit Office that the situation with data is getting worse actually, meaning that it takes more and more time to get the permissions you need as an innovator or a researcher to get data, to connect the data and so on. This is a real problem in Estonia. We haven't done any audit on that, but these are the signals we are gathering.
So what signals, Erkki, are you getting from the field concerning data? And I mean, how big of a problem is that our systems, well, they actually don't communicate with each other? The data doesn't really flow, and how big of a problem is that we actually don't have the data?
Yeah, for me it's very difficult to say because I have only indirect input from our portfolio companies. But I have a data point from a year and a half ago, and I think this was confirmed by another startup, is that they took a quote from our biobank and UK biobank. UK biobank was 4 times cheaper, and everything was set up 2 times faster than our biobank systems in order to kind of get integrated genetic data with the healthcare data. So the market tells me that I think we're a little bit sluggish, we're a little bit kind of outside in, kind of, no, we're not competitive.
When we come back to the screenshot or the data sets, Erkki, that you showed, how is Estonia's specialist care budget allocated today? Is it working well, or should we somehow review the model?
You want the full truth, or my view?
The truth and nothing but the truth.
Okay, cool. So 90+% of our special care money, except for medicines, everything related to services goes to the companies, for the hospitals that we call haiglavõrgu arengukava or hospital master plan. So hospital master plan is a document that says that these 20 companies, hospitals are, and this is not a Freudian slip, by the way, they are important for our system stability, okay?
And they're doing it well.
Yes, and this hospital master plan, surprise, surprise, is 1.5 pages, right? Yeah. So one document, 1.5 pages, no one talks about that in our society.
Well, we are,
determines,
currently.
No, I'm very brave. The others don't really want to take it out. So 93% of the special healthcare money goes directly first to them because they are important for the system, and then the rest is being distributed among all the others.
Now, why is that a problem if those guys actually do a good job?
If they would, and this comes back to my previous system, I would be very happy if their incentives would be in saving money or introducing innovation. But the combination of these two things is super bad.
So you propose to do what? Open the market or change the incentives or both?
So I'm far from saying that it should be open market because we see what happens in the US. They are putting 3 times more per capita into the healthcare and still getting the same outcomes. So I'm far from saying for that, but I think that opening up to the certain amount kind of clearly would help our insurance fund and Ministry of Social Affairs actually to benchmark our governmental system, because currently there's no benchmark. There's no benchmark how any unit economics that is proposed by the hospitals would be compared to anyone, because there are only similar companies or similar hospitals that this cost can be compared against.
Rauno, do you see something in that? Is that something that is worth looking into or considering more seriously?
What exactly?
Well, the fact that haiglavõrgu arengukava hospitals, they get 93% of the specialist care. We suppose, as a society, get the best service from them with the best price. Right. Hopefully that is the case, but perhaps we could check that by opening up the market a bit more than this 7%.
Well, sometimes I joke that I work in the Ministry of Truth.
Yes, that is what I expect from you, the truth.
But actually I'm a civil servant and I am not allowed to participate in party politics, meaning that this is a question of worldview to a great extent. But what I can say is that what we need to open up market in some version in the future, or making this hybrid model work better, or finding the best or optimum balance between private and public sector, is that we need a transparent system. We need a system that is capable of procurement. This is very important, that Estonian Health Insurance Fund has the capacity to procure. We need good regulations, and I don't mean that we need much regulation, but we need the capacity to, well, as I said, fit for purpose. Meaning that we also need very good information, and then again we have to speak about the quality of data, as was mentioned earlier already several times, that we have good primary data, but not so good secondary data. And I started with the thought that the micro level and these large visions are not connected well enough. So we need to work on the quality of the system before we can start thinking about how much open market we are going to have. Or best to say is that these steps that I described, what are necessary to make the system run better, are also necessary when you want to open market, and also necessary when you don't want to open market more than Estonia has already.
Dear audience, thank you so much for posting your questions on Slido. What is preventing Estonian startups to scale, a person asks? What state support is needed so we could raise medtech unicorns? I guess, Erki, this is for you.
Yeah, I just want to propose two things. First of all, incentivize the hospitals to cooperate with the startups and test the solutions. And another part of that is that, find the way how the doctors would want to cooperate and help them. Because currently the doctors are so overwhelmed, the shortage of doctors is very much known. So we don't get the kind of the buy-in from the hospitals and from the doctors enough.
I also can comment.
Go ahead.
We need less control of compliance and more innovative and experimental mindset, which is not so easy to accomplish in public sector, because our public sector tends to be published when we get too courageous.
How do you support or finance public healthcare providers to generate high-quality data? And if the HIF only pays for services provided and not for IT development or innovation? Yeah. Who wants to take that?
Pay for results, not for services or not activities.
We have done several audits on the question of quality. Or should I say, the data quality is a horizontal theme in several of our audits, and we often say to institutions that you should deal with the quality of data in several ways. And currently, we have an ongoing audit on the quality of documenting health services. So we are trying to answer a simple question: what should state do in order to make health records more quality, better?
COVID times brought the shift to telemedicine in Europe and globally, so why didn't it stay as a routine practice in a way we have Teams, Zoom meetings, etc.?
Yeah, I think COVID made really clear to us that some elements of the healthcare or some services can be provided online and some cannot. So I think the society learned, both the doctors, the patients, and the payer learned a lot, how to, if needed, provide the services differently. It taught a lot how to pay for these services, but the pressure was too short-term because not all the systems were aligned to the new reality. And you are right that actually we are not back to the 2015 to 17, but it has been falling back.
Auditor General said in one of our reviews of health policy like 4 or 5 years ago already that this is one of the examples that Estonians have to adapt to, that in the future we will have more and more these kinds of connections. And it's very human that you want face-to-face time with a doctor, but in reality this might be the one thing that Estonians just have to be able to adapt in the future.
And last question from our dear audience: what role can the National Audit Office play in facilitating PPPs in healthcare?
The thing that I haven't spoken about yet today is that in order to innovation to work, you need trust. You need trust between citizens and healthcare providers, between healthcare providers and state institutions, the whole ecosystem. And that is one thing that we can and should do via our audits. Our role is simple. We should ensure that the rules which are in place are followed, and if they are not good rules, we should make recommendations to change them. And this is our role. We put very simply and shortly.
Erkki and Rauno, thank you so much for this discussion. Unfortunately, the clock is showing 0, so we have to wrap up this discussion. Thank you very much.
Thank you.
Ladies and gentlemen, we are moving to the end of our event. And the sun is still shining outside, and I'm exactly on schedule. So I can be proud of myself that this has actually worked out more or less. It's time for our last panel, and I'm pleased to invite onto the stage 2 gentlemen who have a great overview on 2 of the main issues that we've been discussing today. One is cardiovascular disease, and I'm pleased to invite onto the stage head of the heart clinic at Tartu University Hospital, Dr. Alar Irs. And the second issue that we've been talking about a lot today is data, medical data. What kind of access do we have to that data? So I'm also pleased to invite onto the stage Andres Võrk, the health economist at the University of Tartu. Alar, perhaps we can start with you. We know cardiovascular disease takes a huge chunk of our money from Tervisekassa, or the health insurance fund. What part of this cardiology care pathway can already be improved, made more effective with digital tools?
Thank you and good afternoon. And as you said, we are the end of today. So
the end game.
Thank you for having us. And perhaps it's a detailed question to start with. So as a medical doctor in Estonia, or any medical doctor in Estonia, I always forget the things that other countries are still building up, and we're overly critical of the tools we have, or the gaps and tools that we don't still have. So I think previous speakers have said that we have some things that are working exceptionally well in a kind of primary patient care. Would be the national data sets of laboratory data, of images, and of prescriptions. So almost all the data are digital. We have access to almost all of it. And if we have to be critical of something, then it's the user interface applications and ability to integrate these data in real time, if we talk about patient care level. And then we can be critical of other things later. But if we talk about patient care, then what every aspect of cardiovascular care could be improved with the data already there, if it were available at the moment of care for all the healthcare professionals who are involved in the same patient's care at the same time. We have had these references to different pilot projects by the health insurance. One of them has focused on integrating care in one or another disease and having the patient journey covered by kind of a holistic picture, and all of the 6 in the pilot of this year, or the accelerator, we're talking about needing a data integration platform in real time. So we have most of the data, we can criticize the quality, but the ability to integrate in real time is often missing.
So, Andres, you've heard a lot about data today here. I don't know if you've spent the whole day with us. You have? Yeah, wow.
I have been.
Then perhaps an open question for you. What is your takeaway from today, and what would you like to actually criticize that's been said here on the stage, as you're a practitioner who knows pretty well what kind of data we have and how it's been used in policy decisions?
Yeah, thank you for inviting me here. Well, my job is so that half of my time I do lecturing, I teach students, so I'm very happy to be here and talk again. And half of the time I do research, so I'm based on the research, I can then say. First, okay, what hasn't been said here today is that today is International Nurses' Day. Thank you, nurses, for your effort, because that's, I think, the cornerstone of the Estonian healthcare sector. Second, if I talk about data specifically, then, well, I think the first session that we had together with the minister, then there was a kind of they said that, okay, we don't have data to link healthcare data and economic data. And indeed, this is so. And unfortunately, the government doesn't help us here. Because researchers really face difficulties, and policy analysts face difficulties to link the data. And only last month we managed to link, for example, healthcare data and employment data. And now we can answer the questions, what is the effect of cardiovascular diseases on the employment, on wages, and so on.
So now we finally know.
Yes, you just have to ask now me. My students are just writing their theses on that topic. But we had to pay for the government to get the data. They didn't pay for us to do the analysis. Unfortunately, that's the situation that we have in Estonia. But thanks to Statistics Estonia, now it's possible. Yes. So we have more and more data, and that, of course, comes to them when we have the data. Now we are eventually, there's a possibility to do proper health technology assessments, which means we can now see what interventions affect the economy most, where we get gains. Yeah? So we are there almost. Although only at the beginning of this year we now approved a new health technology assessment guidelines, and they very briefly only mentioned the societal dimension. But that was exactly, we didn't have access to data that the minister told. But now, eventually, we will have it. So everything will become brighter and more efficient and better in the future.
Well, if only that happened 20 years ago. But, I mean, it's good that it's happening now, of course.
Yeah.
So I'm just wondering, when will we see the results? When we will have your analysis?
Well, we have defenses at the beginning of June. Come to the university and you will see papers there. So I think already at the beginning or at the end of next year, yeah.
So before the next budget is agreed by politicians, they already have some input from your students?
If they ask, they can get it, yes.
Well, I hope they do. I hope they do. Alar, now, in your experience, what has been the real clinical value of data analytics or even remote monitoring if we talk about, well, the face time with patients, right? We need to decrease that face time with patients, as we heard. This is one of the ways to make the system more efficient, to use the little money we have more efficiently. Do you have any experience where this has actually worked and worked well?
Not that I share every opinion which has been said from this stage today.
And if you don't, please give your opinion.
Yes, and I joined Estonian civil service 20 plus years ago, and I think I have been passed through the levels of both enthusiasm and disappointment of many people on this stage. So realistically, in cardiology, I think there are the biggest use or potential what I see is probably in predictive modeling. It could allow personalized prediction of risks and personalized communication of them in primary prevention to people who are not yet clinically ill, but it could also improve hospital care because you can predict before things happen which patients are at risk and intervene before, and you can avoid things happening in hospital and people staying there for too long. I also see that probably my imager colleagues need to start looking for new jobs. It's not patient FaceTime, but it's computer FaceTime of medical staff. It will be very fast. That is difficult a little bit because of Estonian language and because of less than 1 million native speakers would be the valid medical scribes that would really do my typing work during patient encounters, and I could concentrate on looking in the eyes of the patient. But this will come. It just is an extra effort for a small country. So and not only do I want a document out of it, but I hope we will get the structured data out of it, provided not by me typing or our nurse typing this in. So certainly are relatively advanced little things that will free health professionals' time, yes.
Andres, if we think in financial terms, what would be the economic benefit of using data? I mean, in this early diagnosis or to reduce late-stage chronic illnesses where we spend most money?
Yeah, I'm totally technology optimist. So I think e-services, data, they can help a lot. First, of course, increasing efficiency in the health sector. So if we have better data, better overview, we would just reduce unnecessary amount of, let's say, diagnostic services like laboratory services, imaging, and so on, if we just have the data there. Again, I have to say that, again, we have just studying what is the causes of the increase or drastic increase in laboratory services in Estonia. We have a huge increase, and we do it, I think, a bit too much. So, and better data will definitely, I think, economize on there. And second, I fully agree with Alar that making patient pathways kind of more optimal, like do we have to intervene earlier? Can some people be intervened later? That can be done with better data and predictive modeling. We have done predictive modeling of cervical cancer, for example, trying to see what are the early signs that women should be monitored earlier. So there are definitely gains. And finally, of course, let me mention that better data can also build us or let us to do more targeted policies and healthcare policy. And Estonia has had at least 2 very good cases in healthcare policy. Do we have time?
Go ahead.
Yeah, okay. First is, of course, about pharmaceuticals. Yeah? We have this, what's called, what's an English term, this additional benefit if you consume too many pharmaceuticals. Yeah? Meaning that it used to be basically so that before 2017, yeah, people have to apply. Okay, I spent too much money on pharmaceuticals, then I applied, and then I get some refund. Yeah? Now it is fully automized. Thanks to all these e-systems, I go to the pharmacy, they already know how much I've spent before, and I get the refund immediately. Before that, we had only 0.5% of people who got this benefit because they had to apply. Now it is 15% of people who have, some pharmaceutical expenses, then they have it. So, and it's only data-driven, yeah? So that's where we have benefits. Or take dental care, it's the same thing.
So we do a few things well, at least in Estonia. That's good to hear. More coming after your students finish their research. Alar, do we have international examples where big data in healthcare has clearly led to better outcomes? Is there a country or a case that you like to bring out as a good example?
No.
No. Then we can be the first ones.
Whatever we mean by big data, I think the slight problem with this data talk is that we talk about very many things at the same time. Many people mean gadget data. In healthcare, we mean all that we collect in healthcare. Andres means healthcare data plus other indicators of how people are doing in the society. So I would refrain from telling that there's a huge success story in a country or a big region of a country. But I think it comes down to kind of small, wise uses, and it all goes then back to having the foundation and a few very important things done right. And I'm by no means an IT specialist or a data specialist, but even a doctor can understand that you need to use the same standard terminology in calling things in medicine. You need to use the same data standards and some other IT standards to make the foundational parts of the data system interoperable.
That's not happening today.
And then you can do whatever you want. This is what we're talking about today. And I think many people have already told that the level of actually wanting to do something is different in different countries. I think all countries have the strategy currently. You can go to a relevant ministry page in all countries and you will find the strategy. I think ours is from the February of this year. It's all very wise. If you then read it and go to ChatGPT and ask what Estonia should do, what would be the crucial things to do, you get the same answers more or less in the same order. Whether the ChatGPT created it or read it and then provided the answer, I don't know. But it's so clear what you have to do. The question is, some countries would have then the resolve to go and implement it, and others will have a lot of meetings.
Andres, where do you see we have problems with things getting lost in translation, where we where we haven't actually standardized our data sets in a way that we actually can get meaningful information out of communication between the different data sets? Where does it get lost?
Oh, I'm not an IT specialist, but I understand from the work of my colleagues, what they do is that standardization is a lot of work. To standardize all different data sets, be it data of the health insurance fund, health information system, data that we have on genomics data and so on. And that has taken years to do that. And I think we just are still in the process of harmonizing that data. But yeah, I must admit I'm not an expert on that. Now I lost the main point of the question.
So the question is, if we have a lot of data but it's not readable and we can't actually use it.
Yeah, of course. I mean, as an analyst, the data must be readable, of course. The second thing is, of course, okay, let me perhaps switch a little bit the focus. But Erkki Mölder just told us also and showed us that we have that large majority of the burden is related to actually, let's say, people's behavior, yeah? And we know in Estonia that 40% of the, let's say, the burden of the disease is related to actually people's behavior, like majority is alcohol, then tobacco, and so on. So although we talk about a lot of healthcare, I fully agree with Alar that prevention is the key word. But unfortunately, how do we do that already from the childhood? And because Estonian data show, unfortunately, that already in the childhood, children that come from poor families have 30% higher obesity rates. And there is no healthcare there, yeah, that you can intervene. So it means that we have to start prevention at a very early stage if we want to reduce that large burden of disease that we have later.
Would you redesign healthcare funding to reward results and not just the volume of services? Alar.
Yes, I'm sure probably given the data our health insurance, which was previously called sick fund, has had and the analytical capabilities, it would have been possible for quite some time ago to at least try to measure outcomes. Maybe the patient-reported part is added later, but we should be able to understand. Currently, I don't think anyone is happy. Erkki was slightly cynical about the 20 companies. I'm a middle manager in one of them, but that doesn't make me less human. I'm not happy at all that I get incentivized for providing a second lab test in 24 hours of a thing that should be measured once in a week, maybe, or a month. Or being not interested financially at all about the case whether I have treated and sent home a heart failure patient, whether or not he or she will have an unplanned next hospitalization within 30 days, no one is even asking. So I don't think doctors are very happy, and I think meaning in medical professionals' work is also kind of diminishing if we don't measure the outcomes. So it will have multiple benefits. First of all, we might find out that we are pretty good, because there are people here, at least were people like Lennart or Thomas back there, who have been measuring outcomes and quality in different data sets, and we're not doing so bad, so it might give some shine back to the eyes of healthcare professionals. And then if it happens that comparative institutions are providing very different outcomes, well, there could be preferences in buying. Surely we should.
Andres, what kind of incentives would actually encourage all stakeholders to support a systemic change? Because we've been discussing this, again, for years, but it seems as if things are not progressing as fast as some would like.
Okay, so when we talk about financing, I think we mean two different things, yes? One is how we get the money, And that has been discussed in Estonia. Should it be tax-based, social insurance-based? Should we have more voluntary health insurance? And the second is how we distribute money, yeah? How we pay it. And should it be fee for service, like it is currently, or should it be value-based care? I think in theory, value-based care is, of course, a very nice thing. But if you think that most of the diseases are now kind of lifestyle diseases, they span for half of your lifetime, how you measure what is the effect of one particular doctor on my quality of life. So it's going to be really difficult. Of course, Estonia we have data, yeah? And that, of course, we should try at least. So to try at least, yeah, try to pay for the outcome. Regarding measuring outcome and quality, and that, of course, is a must. We have to do that. I think because we use public money, it should be visible to everyone to see what is the quality of University of Tartu Clinic, what is the quality of other hospitals. We should be able to compare that. I think that's essential that we should do. Whether we should rely that same data to fund them, well, very difficult. Of course, we have currently also quality indicators that Health Insurance Fund uses actually when they distribute the money. It is kind of indirectly influencing also now, but not much. Yeah. But I don't think okay, another topic is how we get the money, but I don't think we have to open that here, yeah?
Well, raise taxes, of course.
Yeah, of course, yeah. Yeah, okay. But
always a popular choice. Yeah, well, or measure every person's glass of wines and then tax them accordingly.
Well, we have excess tax on alcohol, which does basically the same thing.
Yeah. So, what is it that we've actually left out from this discussion so far that you were kind of expecting that we would cover today in this situation where we know that the current system, well, is low on money and we don't have enough doctors. So what is it that you would actually like to propose as a solution?
Yeah, well, we started with on premise that we have to deal with 1.5 times less money, even in terms of proportion of GDP in Estonia in comparison to the EU average. So first of all, we of course have to convince our citizens that they are okay with getting 1.5 times less medical services in Estonia than in other EU countries. And that's for fact, because I think it has been measured that we provide quite a bit of services per unit of money. So we can, of course, try to target things better, avoid duplicating procedures and useless or wasteful treatments, but this will not be of the magnitude of 1.5 times. In percentage, and then we have the up to 2 times difference in absolute terms of GDP. So I'm not sure that this premise holds. But anyway, inside this discussion, I think that data-driven medicine and a more personalized approach, very technology-based, is certainly possible, and it is cheaper than trying to do the same thing in kind of human powers only. For this, I think we need a lot of discussion with society about, someone said the word trust. And currently, if we're talking about opening up the healthcare data, many people get rather worried. People are worried about losing control of their data if they tick a box somewhere. So I think we can much better explain the value of actually using this data, be it in primary patient contact or in creating new knowledge, what Andres is doing, or creating new products. We haven't had that level of discussion. I think we had quite some publicity around our biobank when it was started and a separate law was developed. But I think there's a generation who has not had that discussion and who is much more knowledgeable what can go well or not so well with data. So I think that's a topic that needs to be added to technicalities.
Andres, what is your key message that you would want people to stand up in 5 minutes and take a glass of wine or a glass of water if they actually care about the things that we've been discussing today. I'm going to get wine, by the way.
Well, I think I come back to our first keynote lecture. That was, I think, excellent overview, how health is actually related to broader economy. So I think if one message to take is that don't look at health and healthcare in isolation. Yeah? You have to see the links. And of course, to see the links, you should have data to measure the links. And if you have the data, which we will have soon, as I told you, then we can make better decisions. We can increase efficiency of the sector. We can show the Ministry of Finance that our system is efficient. And then we can also apply for more tax money, I guess. Yeah? And of course, with better data, we can open it to, well, like guys like Erkki Mölder over there, please come on, use Estonia as a kind of a base to try out different innovations. I think that's what can we do.
What an optimistic message. We have one question from the audience. Only 16% of CVD are lifestyle-based. Other are metabolic and socio-economic. Many speakers focused on healthy lifestyle, but what about diagnostics and prevention?
I wonder what the metabolic is other than lifestyle. Maybe we shouldn't understand lifestyle too narrowly. So it means how much we move and what we eat and what maybe also air we breathe and many other factors that are influenceable. Healthy lifestyle certainly is a good thing for prevention. And then I think we should go rather personalized, because we have the experience that there's no lack of knowledge of what people on average should do. Move more, eat less, eat specific things, don't eat other things. But it kind of doesn't relate to most of us. So with all the data available, with all the communication tools available, I think we should be much better in personalizing that message. And we have had a few pilot projects, so I have been involved as a doctor there, trying to convince people with very high cardiovascular risk that things should be done. And although I kind of think I'm quite experienced, I haven't succeeded. So at least in Estonia, if we design these interventions in prevention, we should much more listen to people dealing with psychology, social sciences, how to target it, where to target it, and what are the implementation measures for different groups of people. They are not patients. We're trying to prevent them becoming a patient. So I think the implementation and communication part should not repeat the you should not eat or drink or move more. We should be more clever with all the technology available.
So, and this is something that the next and probably the last question from the audience in this conference actually addresses: how data and AI can provide for better primary and secondary prevention, how to incentivize general practitioners to apply such insights. Again, a tricky challenge.
Well, okay, regarding family physicians, yeah. Well, of course, I think there are smarter people now in the audience, I think, who know all these fancy dashboards that our family doctors have on patients, that collect data on individual patients and already then provide also recommendations what to do with the patient, how to incentivize them. So, okay, we have currently incentive system or GPs, for GPs. If they do more preventions, they do some specific tasks and specific analysis, they are paid more. So we have incentive system there. They also have incentive to kind of economize. I mean, well, we talk about private healthcare a lot, yeah, but actually all our family doctors are actually private entrepreneurs, yeah. And half of the money that they take out is not in terms of wages, but in terms of dividends, profits. So they have a huge incentive to actually economize, not to see the patient so often, yeah? So they have incentive to, well, invest into the prevention. So I don't know what else to do.
For the first question here, how can data help? Maybe you have been talking a little bit in a too paternalistic manner here, and maybe that's one of the problems in our prevention also, that it should be the person, him or herself, to actually should try to hand back the responsibility, at least in preventive medicine, to the person involved. And I'm sure we can do that with a personalized set of data and personalized recommendations. Because this model that, be it GPs, there are about 900 probably in Estonia, or cardiologists, maybe 100 in Estonia, that they would go out and prevent cardiovascular disease. That's just kind of illusion. So whatever we can do with the data to give it back, to involve the person, him or herself, that's certainly going to move mountains. We are not going to move the macro indicators of cardiovascular health with specialized or even with primary care healthcare, I'm afraid.
Well, in a way, it's a cheerful message that everyone can now take the power back to themselves and take care of their good health at the reception that is about to follow. Ladies and gentlemen, an applause to Alar and Andres. Thank you so much. Ladies and gentlemen, thank you so much for taking part of today's discussions. Thank you so much for all those questions that you put forward. I'm afraid the last questions on AI and data will be left for the reception that is indeed about to happen. Now, we've talked about a lot of complex issues today, including how to fund healthcare more sustainably, how to turn data into real outcomes, and how to make innovation more than just a buzzword, but instead something that improves lives and actually builds economic value. I think one message came clear pretty well, that healthcare shouldn't only be looked at as a cost, but as a lever for growth and better futures, not to mention better lives that we all want to live, hopefully longer and healthier. Now, the conversation doesn't actually end here, as already noted a few times, and you probably might have heard the glasses being put on the table over there. There's also water, by the way, but also some wine. I'd love to invite you all to continue the dialogue at our networking reception, kindly hosted by the Embassy of Switzerland. And in behalf of the organizers, thank you again for being part of the Swiss Healthcare Innovation Day, and I hope to see you all in a healthier future. Thank you very much.